Thank you, Dustin. Good morning, all. This is the convening of the Central District Board of Health meeting for Friday, August the 30th. It is 8:30 a.m. I am the presiding chair for Elmore County. Betty Ann Middleton. I serve with Representative Megan Blanksma. It's really a treat to see faces again, partial faces, that is. And we have a big agenda today, so we will get right into it. And we'll go ahead and call the meeting to order with roll call, starting with Ada County. Raul Labrador.
Here.
Jane Young. Here. Here. Elmore County. Here. Megan Blackstock. Thank you, Megan. Boise County.
Ryan Sturm here.
Okay, thank you, Ryan. And Valley County.
Mr. Hasbrook here.
Thank you. Okay, folks, we do have a quorum, so we will proceed. Director Duke, are there any changes to the agenda?
Madam Chair, I did not have any changes to the agenda, but I was informed by staff that there were some members of the public who would like to make some public comments. If you would like to offer that as an opportunity, we can do that at the start of the agenda. Typically, during meetings, commissioner meetings, city council meetings, when there's people providing public comment, they are limited to 3 minutes. So whatever your pleasure is, we'll
Certainly. Do we have anybody that would like to speak at this time? Go ahead, madam.
Sandy Curran. I am a parent of 3 children in the Boise School District. I would like to speak to item 4 and request that community and school guidance from the CDC require board approval.
Any further comments? Okay, thank you for your input. All right, proceeding under new business, we need a motion to vote on the minutes from our May 21st board meeting. Do I hear a motion?
Madam Chair, I'll make that motion. We approve the minutes of May 21st.
Thank you, Commissioner Hasbrook. Is there a second?
Second.
Thank you. Any discussion before I call for a vote? Hearing none, we will call for a vote starting with Ada County. Jane Young.
Jane Young, aye.
Raul Labrador.
Raul Labrador, aye.
Elmore County.
Megan Blanksma, aye.
Boise County, Commissioner Sturm.
Commissioner Sturm, aye.
Valley County.
Mr. Hasbrook, aye.
Thank you. Motion to approve the minutes from our May 21st board meeting have been approved. Proceeding on, we have the introduction of our new division administrator for family and clinic services, Gina Pinnell, and an appreciation for our retiring division administrator, Chris Bain. I'll turn that over to Director Duke.
Thank you, Madam Chair. So Chris is joining us virtually. She's in the top right of the screen, and I just wanted to take a moment to recognize her and her work. I still recall back in 2016, it was about this time of year when Chris came walking into the interview conference room for the Division Administrator of Family and Clinic Services. And I just remember distinctly this was going to be her job. She knew it, and she had good competition, but she was definitely the leading candidate. She knew what she wanted to do with Family and Clinic Services. She had been working at the Department of Health and Welfare at the time, and it was a contractual relationship between us and Health and Welfare. But many of the programs she stepped in to lead, she was already incredibly familiar with. I would say she transformed our clinics from offering basically the same preventive health services we had offered for decades into a clinic that would meet a broad scope of preventive health needs for both individuals and families, from children's oral health to our women, infants, and children nutrition program, which is the largest clinical service area we have to offer. expanding our behavioral health services. So instead of having to do referrals, we were able to offer those services in-house. And expanding our home visitation services, which started just before she came on board. When she joined our team, we had 3 separate entrances, as many of you know who were on the board. You had to come into one entrance for WIC, one for immunizations, one for reproductive health. Now they all work together and the client experience is much more seamless. She has led a team of almost 80 staff, which is the largest division within our agency, and has done so with an impressive commitment to her team and their individual success. Role model for our agency values, without exception, always a smile, as you can see now, positive attitude, and an optimistic outlook, no matter how difficult things got. And certainly difficult they have been for the last year and a half. As Chris enters the next chapter of her life, called retirement, I wish her all the best.
Hey, thank you, Russ, and thank you, Chris. It's been a real pleasure to serve with you.
Thank you, Madam Chair.
Now, yeah, please.
Yeah, thank you. I just, I won't take a lot of time, but I just wanted to give a heartfelt expression of thanks and gratitude to Russ and this Board of Health and the entire CDH team for allowing me this opportunity. It really has been a tremendous opportunity and a great way to close out a professional career. I have nothing but gratitude toward the entire CDH team for their unwavering dedication and professionalism, not only during the COVID-19 response, but honestly, there's so much work and daily activities that happen day in and day out by many staff that we don't see in the forefront, but they're there daily working and performing activities that all support our CDH mission. And it's just been a real honor. So thank you again.
Thank you, Chris. I wanted to introduce our new division administrator, Gina Pinnell. Gina. And Gina's no stranger to Central District Health. She was actually hired in 2015 as our statewide healthcare innovation plan grant manager. She did that for a few years. That was a 4-year grant, and then she moved into a project manager role, which allowed her to work really with the entire agency, spent a lot of time with the Family and Clinic Services Division, helping with strategic planning and performance metrics, and just think about things like home visiting. I know we work closely with Representative Leitzma to allow that to have coverage, either state plan amendment or coverage through Medicaid, which is sort of a real success for us, and I think for the entire state for sure. During COVID, she stepped into the liaison role for schools, and as you all know, this was a really big deal for our schools, trying to figure out how to educate kids at the time of a pandemic that really unprecedented in certainly all of our lifetime. She did an exceptional job helping them navigate the difficult decisions. She became our clinic manager at the end of last summer. That was after Brandon Atkins had left that post. And now she's a member of our leadership team, so you'll have a lot more opportunity to work with her. I am confident she'll accept the baton from Chris and take off running and do an excellent job for us. So welcome, Gina.
Thank you, Jason. Okay, moving on, we're going to have a review of our COVID-19 status report by Lindsay Haskell, our Communicable Disease Control Manager.
Thanks for having me to present. I'm Lindsay Haskell. I'm the new Communicable Disease Control Program Manager. And I wanted to talk today just about our current state of COVID in our health district. There's been 5 factors that are important for local decision makers to know about, to understand what's going on in the community. when to have or relax mitigation measures. And I will talk about several of these in my presentation, and then a later presentation will talk more about vaccination coverage. So this is a snapshot of what has happened in our district throughout the COVID pandemic. We've had a total of 62,328 cases reported and 525 deaths. That accounts for about 12% of our population, but we know that's underreported or seeks testing or has access to testing.
I have a question.
Yes.
Go ahead. So 490 confirmed deaths, is listed, how is that listed on the death certificate? Is it listed that it's COVID related? Is it a heart attack? Is it strictly COVID? I need some transparency on that.
For the deaths that are reported to us, it's something that's reported on the death certificate to vital statistics, and then vital statistics reports that to public health. And it has to have COVID or COVID related on the death certificate.
So these aren't all necessarily COVID deaths. They can have COVID related on it. So I can die of a heart attack and be diagnosed with COVID, and I'm going to show up in this number.
If it's reported the vital statistics on the death certificate with COVID, it's reported to us as a COVID related death.
Okay, so these are two different things. That's what I'm asking. When you get it reported to you, is it reported as a COVID death, or is it reported that it's a death COVID related?
I don't have access to see that. I could ask health and welfare. They just report it to us as a COVID death to update our systems.
Okay, if there's a way to provide some more transparency on that, I would really love to see it.
I can ask for
Thank
the
you.
specific details. Okay, so 12% of our population, but we know, again, a little bit underreported. Right now, in August, we're averaging a report of 191 cases per day, but that continues to increase. In the last few days, we're seeing 200 to 300 cases a day. To compare that to what we were seeing earlier this summer at our low, it was 27 cases a day in June and 71 in July. And when we look back at last summer, when we were in the surge, it was about the same at that 190 cases per day. All of these numbers for the specific counties closely align to the populations. So breakdowns of percent of what our population is. And the other piece to note is reinfections are possible and they're not tracked separately. So some of these numbers could be reinfected individuals. So when we talk about capacity for early detection, that was number 4. There's different things we can look at. That's the ability to test and having surveillance testing in place. And another metric we look at is percent positivity. Our percent positivity right now is right about 11. It's been increasing since the end of June, and anything above a 5% is considered high. Means not enough testing is happening in the community, and you'll see our testing numbers, that blue bar means our testing's increasing, but our percent positivity is increasing.
Chair,
Go
if I may, I have another question. I mean, I can hold them till the end if you prefer.
No, go ahead.
Okay, so are we tracking, when you talk about percent positivity, I happen to know from firsthand knowledge that you're getting calls from folks that say are completely asymptomatic and only find out that they've got a COVID positivity test because say they're going to Hawaii. Are we, and from what I'm understanding, that is not an infrequent call to the call center. Firsthand experience. And so my question is, are you tracking that stuff independently as far as asymptomatic versus symptomatic and going to get a test because they're concerned about illness, or is it all just getting lumped together as in the positivity rate?
There is a way to track symptomatic versus asymptomatic. I don't have the numbers in front of me. We know asymptomatic individuals can transmit, so they're all counted the same.
Okay.
So the blue number is the amount of tests that happen in our health district, and the orange is what percent of those is positive. So again, sitting right about 11%. And considered not enough testing to know truly what's happening in our community, and that we need to have more testing happening for individuals to know their status, stay home, isolate, take different precautions. We're also seeing test turnaround times increasing as some labs and healthcare systems have some capacity constraints. So this is the case rates. It's the 2-week average daily case rate for a population of 100,000 for the district. You'll see we had our first peak last summer, second peak in the winter, and now we're headed up towards another one. Right now, our case rates are mirroring as we were coming out of the surge in January, but seeing that line steeply increasing. I'm presenting the 2-week average because that's what we've presented historically. It is a number that is a little bit more stable than if you were looking at every single day. We're looking at the 2 weeks prior and looking at a population case rate of 100,000 so we can compare different populations and have a standard.
Madam Chair, I have a question.
Yes, go ahead.
Let's see, it seems to me, when looking at this graph, there's probably gonna be a drop and then another peak in mid-winter again. Is that kind of your feeling too? Is this a cyclical infection rate, or is it tied to school openings, or do you have any ideas? This is just a repeat of a year ago.
It is, it's hard to compare, and as we go through, I'll talk more of how even right now looking, now with the Delta variant, it's hard to compare. We've had hospitalizations, different transmissibility, different severe illness, and it's hard to predict what's gonna happen just with the rapid changes and variants happening. So there's ideas out there, it could be cyclical, nothing's been proven with that. There's also times it could be tied to different activities, release and mitigation, openings, all sorts of things. So it's hard to predict.
Well, like bottom of August, last year, between August and September, that's about when school opened. I'm not saying that schools caused that increase in November, December, or January, but may help us figure out a way that we can adjust our philosophy on this. This is gonna become hard every fall, or it's gonna become worse in the winter time. I'm just kind of prepared for it, I guess. To me, that shows that even though the school opened in the middle of August, or whenever it was, I don't know school opening dates, but there was a big lag time before we even saw any kind of an increase. So maybe it's not something that is starting at the schools, maybe it's something to do with cold temperatures, or just trying to speculate that this looks to me like almost a repeat of last year.
Knowing the way it transmits across.
Madam Chair, this is Raul.
Yes, Raul, go ahead.
I'm having a hard time hearing the speakers. There's something wrong with the microphone. Both Commissioner Elt and the speaker, they're hard to hear.
I'll try to speak up louder.
Apologize for interrupting you.
Can you hear us now, Raul?
There we go. Thank you.
Understand, because they do not reflect the Air Force vaccination rate, is that correct? And that is actually a large, I think,
Yeah, so I will specifically talk about Elmore County, and I can talk a little bit about vaccine, and I believe Natalie will a little bit later in her presentation. All right, so we'll move on. So we saw case rates. These are the reported case numbers per week. So very similar trend, just different numbers. And again, seeing that increase, saw a little less of an increase this last week for the first time since the end of June. Still increasing, and other indicators such as wastewater data show that we would be set to continue to increase at a higher rate again. So right now we are at, we had 1,365 cases last week, and at the peak we ever saw was 3,362. These will be important numbers to remember as I talk about hospitalizations later on, we're at very much lower numbers than we were at our peak back in November, December. So here's the set for Ada County specifically. Again, peak was 3,200, right now 1,300. For Boise County, peak was 39, now seeing in the teens. Elmore County peak was just over 130, now seeing in that 50s to 70s range. And for Valley County, peak at 74, saw 40 cases last week. The next indicator.
Yeah, I had a question. Can't remember what, I mean, yes. Counting folks from getting reported into Valley.
So it is reported based on primary residence. So visitors, people with a second home that are only there for a short time are not reported under Valley County numbers. So one of the other metrics we look at is health system capacity. One way to do that is through hospitalizations. This is the number of patients in our hospitals, not counting people in the ICU. Looking at our trends over the summer, and that again, we're sharply increasing with 99 most recently. The average age of those hospitalized has changed over time. It has been between 44 and 66 during this recent time frame. Last winter during the surge, it was 64 to 74, and last summer during the surge, it was 60 to 72. So seeing younger age ranges or a younger average age with the hospitalizations. And we're also hearing about concerns for capacity to handle any other mass casualty events that could happen. Something like a large accident, weather events, or man-made threats. Because the healthcare systems are surging to treat COVID. Again, very high numbers.
Question, which
so this is for hospitals located in our health district total. So St. Luke's, VA, St. Al's, and I feel like I'm forgetting one. So St. Luke's Elmore, St. Luke's McCall, St. Luke's Boise, and Meridian, St. Al's, and VA. I'm not, Natalie, can you help me out? Does Cascade report into IRTS?
Yes.
Okay, and Cascade. Yeah. No, West Valley is Region 3. Yep. And when we look at these hospitalization numbers, so this graph is just for the summer. If we look back over time, they're very similar numbers to what we had in our surge or peak in November, December of last year.
Those numbers.
Hospitalizations. They were in the, for our residents, they were in the hundreds. For the Valley, looking at district, Public Health District 3-2, they were in the hundreds, like couple 200 to 300s. For this graph specifically is those in the ICU. So you will also see a really steep increase in the amount of people hospitalized with COVID in the ICU in our district. These don't, I didn't say on the last slide, they may not just be members of our health district, but people hospitalized in our health district, so impacting our healthcare systems.
So when these are traveling, people are-
Yep, or people moved from other areas where their hospitals don't have capacity. We see, so this level with 44 in the ICU is very similar to what it was in December of last year. And one thing we look at when we're looking at hospitalization, it's a little bit of a lagging indicator. It takes time for people to test, become ill, become hospitalized. So it tends to lag behind case reports, anywhere from a week to 2 weeks. I do. Again, where this is hard to compare, where we had almost 2 to 3 times as many cases and less hospitalizations. Now we have less cases and more hospitalizations. We're seeing a steady increase in cases, a steady increase in hospitalizations. I would expect that to continue as the cases continue to rise.
Madam Chair,
Yes, Raul, go ahead.
do we know the severity of these cases and whether these hospitalizations are ICU, emergency room, or anything like that?
The numbers I'm presenting are not emergency room visits. We are not tracking those in the same way. So the first slide had 99 people. They were admitted in like a medical surge overnight, could be long-term, couple of days, but just admits to the hospital. And then on top of those 99 admits, there was 44 people in the ICU.
Sure. Raul, just to give you a this morning, and they got medical ICU and 100% of them are vaccinated. The average age is 53, 10 are intubated. So just from a data perspective, that's what I got this morning for St. Luke's Boise.
All right, thank you.
Move on to a couple other kind of hot topics, things I've been asked frequently about. Vaccine breakthrough cases. So the vaccine remains highly effective. We have had, I'm using a little bit older data for this, just based on the data of what I have for vaccine breakthrough, confirmed with Health and Welfare. So we have had 1,058 vaccine breakthrough cases as of the 14th. Of those, there's been 4 deaths and 28 hospitalizations. We have over 255,000 people fully vaccinated of residents of our health district. So that means only 0.4% of individuals fully vaccinated have developed COVID, and 98.3% of our cases have been in those not fully vaccinated. So the vaccine remains highly effective at preventing infection, severe illness, and death. Another thing I'm being asked about frequently is about the changes in age groups. So this shows kids that have been infected with COVID over time. Again, at our peak, we saw 357, but we were at over 3,000 cases a week. Now we're just over 1,000 cases a week, but seeing over 250 children being infected. Right now, we're seeing about, since spring of this year, about 10 to 20% of our cases reported are in those under 18. Before, earlier on, we were seeing that as less than 10% of our reported cases. Also looking at comparing 2020 to 2021, we saw a small decrease in the percentage of cases being hospitalized, but a large decrease in deaths from COVID, which we anticipated with vaccine being available. Now we're starting to see an increase in hospitalizations and those in younger ages. This state,
Madam Chair, this is Raul Labrador again. I just want to clarify, and I don't think you meant to be misleading, but younger ages is 30 and up. We still see 30 and under the age of 18, there's been 0 deaths in Idaho. Under the age of 30, there's been 6 deaths in Idaho. Isn't that correct?
that is correct. So,
Yeah,
um,
I just think that we need to be very careful because, you know, you have children that are thinking right now that they're at high risk of dying, people under 30 that think that are at high risk of dying. And so far, the data does not support that. We are seeing a small increase in 30 and up, which is terrible. But I just, you know, as we go on to the next topic, when we talk about schools and other things, there's an effort by the media and others to scare the hell out of parents, and I think we need to be very careful with that.
yeah, and to clarify on the last side, I didn't read exactly, but it's in, I specified ages 30 to 70 are where we're seeing those deaths now, and that 30 to 50 for hospitalizations.
Correct, and I didn't think I saw this slide, I just wanted to make it clear for what the statement that you made. Thank you.
This data is available. Most of this is available publicly, whether it's on our dashboard, which is updated Mondays and Thursdays, Health and Welfare's dashboard, which is updated Monday through Friday, and then CDC's COVID tracker is updated daily. Overall, in talking about the 5 areas that decision makers should look at for COVID-19 in their area, number 2 was hospitalizations, and our hospitalizations, including those in the ICU, are rising. Cases reported are rising. We're seeing about a doubling every 2 weeks. All of our counties are considered high transmission. Our percent positivity continues to increase, and all the indicators we're monitoring continue to go in the wrong direction for the last month. We don't have any publicly declared outbreaks or clusters outside of those in long-term care facilities. We are seeing an increase in cases from long-term care facilities being reported.
Good. Madam Chair, can I ask a question about that percent positivity? So do we have any data on who's getting the test? Because when we initially started with COVID, there was a big effort for every single person to take a test. And if we've seen a percent positivity right now, I assume that the people that are getting tested now are mostly the people that are feeling some sort of effects or they feel symptoms. So it actually makes sense that the percent positivity would be higher. Am I misunderstanding that?
More people are also being tested. So as more testing happens, we want to see that positivity stay low.
Yes.
And we're seeing an increase in the amount of people being tested and the amount of those being positive.
Thank you.
Just a little bit, if we remember, this was a discussion we were having too. We were less concerned about and so while it's been true, it's not necessarily looking for things. It was hospital and medical capacity.
Yeah, it's an indicator of what can be happening in the community, so what could impact healthcare capacity.
Madam Chair, feel like system is going disease, and so they're having theirs. Maybe it's right. The only reason hospital out of room now seems to be still quite a left in hospitals. We talked once about there was something like 560 beds or 530 beds. I don't remember the number. And to me, if we're around 130, 140, we still have room to go for the hospital capacity. Is that correct?
Hospital capacity is changing frequently. Right now, our hospitals, it's in the news, and the reports that they are stressed, that they were full from regular types of illness and accidents, things with people being out and about in the summer. They have been able to move and pivot to help treat COVID, but there is concerns as that continues to increase, as well as having the normal hospitalization. So I know at different points, I believe St. Luke's added some ICU beds. They're doing certain incentives for staffing to maintain staffing levels, but healthcare capacity is a big concern currently.
I think one of the things too, Madam Chair, that I'm hearing out of the hospitals is not as much as the capacity concern is the stress on the healthcare workers. And that some of the interactions they've had with patients and families and just that heightened sense of anxiety and frustration. So that's even more so than whether the physical bed exists or not. There's been some concerns about how they're being treated. And so that's unfortunate. Yeah.
Madam Chair, this is Raul Labrador again.
Yes,
Do you have any data piggybacking on the previous comment? Do you have any data on the stress level that physicians and others and nurses in particular are having, with some of the mandates at the hospitals? How's that going to help with the capacity at the hospitals when they're putting the people who were in the front lines for the last year without vaccines, now they're forcing them to make a decision in some cases that they don't want to make?
That is not something I have any data on or access to data on. Would probably come from the hospitals themselves.
Thank you.
Any further questions or discussions for Lindsay?
I don't have any questions. I just think it's gonna be really interesting to see what this next trend does through the next winter. So we keep doing this every winter, then we need to figure out a different strategy, more severe strategy or something. This is gonna be like the flu. Around every fall and makes everybody sick. We need to plan for it. Did a great job. Thank you.
Thank you.
Thank you, Lindsay. Okay, moving on to new business item number 4. This is a discussion and vote on board involvement with CDH's guidance to communities related to COVID-19 by Mr. Labrador.
I'm sure.
Yes, Russ, go ahead.
I just, Noel and I have talked about this a couple of times, so we do have staff here. We have our medical director, Dr. Sandy Mudge, Lindsay, who just spoke, and other team members, Natalie, who help answer questions. So as you guys have the discussion, even though we don't have a formal presentation by one of our team members, we have plenty of staff here who can answer your questions.
Okay, thank you.
Thank you.
Go ahead.
Before I start the discussion, I'm having a hard time hearing all the people there, and I apologize that I'm not there now. I kind of regret not being there because I think we would have had a better discussion if I were there in person. But if there's a microphone or something that can be passed around, or there's a different approach, because I'm just having a difficult time hearing somebody who doesn't have a microphone in front of them. So to start, as Russ and I have discussed, in July, the CDC came out with some guidance statements about both children in the schools and the requirements for people to wear masks if they've already been vaccinated. And immediately, I can't remember if it was 1 day or 2 days or 4 days after that guidance came out, the CDH adopted that guidance and sent it out to the public. And I was very concerned about that because, to me, even though it was just a guidance and not a mandate, it appeared to the public as if it was a mandate from the CDC. And many businesses, schools, government entities in the state started looking at that guidance as if it was something that had come directly from the board. If you look at our bylaws in CDH bylaws, section 2 of CDH says that the duties of the members of the district board of health the district board of health shall have the control and policy setting functions of the district health agency operation. In section 13, the duties of the secretary to the board, the secretary has the function of suggesting courses of action or policy to the board for their action. And I know, and you know, Russ and I have talked about this. I don't want to be overly prescriptive in every single thing that the staff does at the board, but I think we're living in interesting times, and we're living in precarious times when, in my opinion, the CDC sometimes comes out with statements that are more politicized than they're science-based. And I think there should be a discussion at the board before some of these guidances come out. And I wanted to have this discussion amongst us so we can debate. Before I go into the 2 specific guidances that particular edict came out with, I just wonder if any members of the board have any thoughts or questions about the initial presentation, the initial thoughts that I've had on what we should be doing as a board.
Madam Chair, to some degree, I agree with Raul in that there were some, my concern was a Facebook post that came out that was an endorsement of a position of the Boise City mayor, which I know is in complete contrast with everyone basically in Elmore County. So I had a frustration level that Central District Health was endorsing a position of a mayor in Ada County. And so I understand the position that Raul's posing it's a concern, because I don't know that I want my name on things that come from a Boise City mayor. And he's right, the impression is that the board is involved in these types of endorsements. My experience was just with the social media posting. My question is, and it's always been throughout my service to the board, is I'm a big believer in exactly what he was talking about on policy setting. And so I guess I feel uncomfortable addressing just COVID related, things. I think that there probably needs to be an overarching board policy about how things are endorsed or how things are posted. I did talk to Russ about whether there was a social media or a press release type policy of what goes out and how that's determined. And my understanding is there's no formal policy on how that goes. And so I think as part of this discussion, I think that it might be productive for the board to provide an actual policy on how these endorsements of whatever entity go out, rather than, as Raul has already mentioned, being prescriptive on certain issues.
Thank you, Megan. Thoughts?
I don't know, Madam Chair, I guess my feeling all along, I think our big function, and I think we've done very well with it, is we discover an issue, whether it's COVID, whether it's an STD or an AIDS epidemic or whatever, and we get that information out to the public, and the public is forewarned to protect themselves. That to me is our job. And I know a lot of the heat that we took off last year was the fact that we mandated all these schools to do all these different treatments for kids, and we never did any of that. And we were kind of blamed for that whole process. We advised the schools, and it was up to the school and the school board to decide what to do, same as everybody else. But we caught a lot of heat for that because everybody thought that was coming from the health districts. And when the schools come to you and ask, what do you guys think we should do? And we give them suggestions, it's not mandated that they do that. But we have done everything we can to notify the public, which is our job, of a health crisis. And I think we've reached a point now where, because of the politicization and because of some of the crummy Facebook stuff that's gone out there, we're losing credibility. not only us, but the CDC and all that. And to me, I think we reached a point where we have told everybody, everybody knows about the virus. And you gotta let people control their lives and let the chips fall where they may. And we're seeing that now in this latest rise. 98% of the people that are in the hospital are unvaccinated. That was their choice, but we did our job here in the health board, letting everybody know that these are the things that you might want to think about doing. And I'm really proud of the fact that we did that. I think we did a great job. That's my thoughts.
Thank you. Yes, Dr. Young.
Raul, I had some concern or question about what you mean by guidance. You say that we're offering guidance and how that fits with what we have.
Madam Chair, that's I can't tell who asked that question, but that's a great question, and Russ and I have had this discussion back and forth because, as I indicated, I don't want to be overly prescriptive, and he gave me some examples of some guidances that are really innocuous that come out of the board. I just think on this issue, especially on something like mask, suggesting that we have masks in schools and suggesting that we have masks, that a person who's vaccinated double mask, has to mask in public. Those are things that are not science-based. And I'm trying to figure out how, as a board, we can distinguish between certain guidances that are innocuous and these kind of guidances that do not appear to be science-based. And I just want to speak to the two specific guidances that came out from the CDC, so you maybe understand a little bit better where I'm coming from. Let's talk first about asking fully vaccinated people to mask up. If you remember when that guidance came out, the public just went crazy because they thought, okay, these vaccines don't work. And I think one of our main goals as a board is to encourage people to actually take the shot, to actually take the vaccine. I don't think we should be mandating it, but I think we should be encouraging people. And the reality is that more than 99.99% of people fully vaccinated against COVID-19 have not had a breakthrough case resulting in hospitalization or death. And this is actually information coming out of the CDC itself at the same time that it came out with this guidance. As in more than 164 million people have been vaccinated, fewer than 0.001% of those individuals have died, and fewer than 0.005% were hospitalized with COVID-19. About 3/4 of all reported breakthrough cases were among seniors 65 or older. So we are trying to encourage people to vaccinate, and yet the CDC comes out with a guidance that says that we have to wear a mask in public if we're vaccinated. I actually think that does the opposite of what our mission is. That actually discourages people, those who are unvaccinated, it discourages them from actually being vaccinated because they believe that the vaccines don't work. And I think that's something that should be up to, that before it comes out as a guidance from the CDH, we should have a discussion about that because we want to send the right message. When the CDC changed its mask guidance in late July to suggest the vaccine, and the worst problem with that specific guidance is that there was no data at the moment of the guidance that they published supporting that guidance. In fact, it was roundly criticized because they did not cite a single study supporting the guidance. Eventually, about a week or so later, it cited data from Provincetown, Massachusetts, alongside other studies which found vaccination doesn't totally stop transmission of the virus. But absent from most of the national discussion was the fact that according to available data, as we just discussed, breakthrough cases were still exceptionally rare, and vaccinated people still didn't transmit the virus nearly as much as the unvaccinated. So, and even that study was a small sample of just 127 infected individuals who were vaccinated, in addition to 84 partially or unvaccinated. So we're setting the guidance that most people, frankly, in the state see as policy for the state, based on a study from Massachusetts of 127 infected people, and other studies that haven't been peer reviewed or anything. I think that's something that we should discuss as a board before it comes out from CDH. Now, on the mask mandates, just this last week, there was an opinion piece uh, on the case against masks for children. And this was not, it was in the Wall Street Journal, but the authors of the study were Dr. Marty Makary, professor at the Johns Hopkins School of Medicine and editor-in-chief of MedPage, and Dr. H. Cody Meissner, chief of pediatric infectious diseases at Tufts Children's Hospital, and a former member of the Food and Drug Administration External Advisory Panel. So these are not my right-wing friends. These are like people that understand the science and study this every single day. And they asked the question, do masks reduce COVID transmission in children? Their answer, believe it or not, we could find only a single retrospective study on the questions, and its results were inconclusive. So once again, we're sending out a guidance that now the Boise School District has adopted. People are pushing the West Ada School District to adopt, that is not based on a single conclusive study showing that masks are beneficial to children. And in fact, they said that the opposite is true. The possible psychological harm of widespread masking is an even greater worry. Facial expressions are integral to human connection, particularly for young children. They talk about the fact that authorities in many places have taken the cue to impose mandates, and that this is actually harmful. It leads to depression. I mean, I can go on and on and on, but these are serious issues that we should be discussing as a board before they come out as a guidance from the CDH. And I just think we need to be very careful, especially when we're dealing with the health of our children, because there's going to be ramifications for these kids for years to come, psychologically, socially, educationally. There's studies showing that they're already behind a year in school. And if we keep doing these things to our kids, we're not going to have a future in this state or in this country.
Madam Chair, yes, Megan. If I may, I just would like to reiterate my point, is that I understand and I agree with what Raul's saying. I hate to target one issue and not have an overarching policy. So I think that it would be better to have the overarching policy that says maybe, and I'm going from the cuff here, something like any recommendations that come from the CDC before are promoted by central district must be reviewed. Or just, I think that we need to have a broader policy. And I'm looking it up here and my memory is failing me. But I do know that if I remember correctly during session, the ability to deal with mask mandates and whatever's happening in the schools has been more centralized with the State Board of Ed. So if the concern is this particular issue with mandates in schools, that's the overarching governing body. And that's, I don't want to do their job, I guess. After living through however many months of COVID, that's a them problem, not a me problem. And I think that's where it should stay. But I do agree that a better policy of what is promoted by this board as to what information is coming, that I think that we need a better policy.
Sure, this is Zoe. I guess, Raul, can you hear me all right?
Yes, I can.
My only concern about it is if we start going in as a board and And I'm not saying it's not a good idea or a bad idea, but I'm concerned about our credibility. If we start going against what CDC is recommending, somewhere along the line, we're gonna make a big mistake and then we're gonna lose our credibility. That's my concern. You guys all know, we've gotten all kinds of studies on the, emails and texts from different places all over the world, and try to read those and understand them is a little bit tough for this old cowboy, but to me, again, it comes back to, here's the best science available at this time. No, I know, for example, in our area up there last year, our kids did not wear masks in both schools, McCall and Cascade, and they got along just fine. But they did an alternating schedule and they social distanced the kids, and the big issue was sports. Because mom and dad and grandma and grandpa wanted to come to the basketball games and the football games, and that's where we got, I think, a lot of people sick. That was a tough one there, and so at that time, that was the information we have. Now we know that this disease is not as serious for young people as it is for super seniors, and so we need to rethink some of that. But I want to just make sure that we don't lose our credibility by nitpicking what CDC says, and we're going to support this, but we're not going to support that. As always, this has always been a school board decision for every school in the state.
Madam Chair,
Yes.
I think we need to decide if we're talking about policy and how the board's gonna function versus the specifics. Because if
Right.
we are gonna talk about the specifics, then we've got experts in the room to listen to as well. And so we need to kind of decide which way we're,
Right. And that is a mission policy.
yeah.
Oh, Madam Chair,
Yes, Megan?
I guess, my question would be, is there a specific point of action that we're looking to take, or this was just intended as an overall discussion to come back with a policy, say, at our next meeting in October? I guess I'm just wondering, because we could discuss this all day long. I mean, all of us have really strong feelings about it. And so I just wondered what are we doing?
So I would like to have I agree with Megan actually that we should have a policy set for some of these things. My only concern as we discuss this policy, I couldn't agree with Elt more that we want to get the proper science out there. And that's why I spoke about these two specific issues, that there's absolutely no science backing what the two guidances were from CDC. So somehow we have to come up with a policy for the board to discuss these things. But what concerns me the most is that, like I said in the beginning, the CDH bylaws already say that it is up to the board to set the policy for the district health agency. And we need to maybe figure out how we further define that. What is policy and what is not policy? And maybe, this was a good first discussion, and we need to figure out how we do that, because I think the public is confused. The school boards, when they saw the CDH, they're being inundated with calls both ways, because they say, hey, the CDH just recommended this, why aren't you doing it? Or some people are on the other side and say, CDC is wrong, why are you even thinking about this? So we need to figure out how we set forth that policy, and we need to be a little bit more clear.
Madam Chair.
Yes, Megan, go ahead.
Yeah, and I totally agree. I mean, we're being used as a tool. And it's not, there are people who are setting policy making assumptions that we're making endorsements of policies. And I agree, it's a totally good point. And that's why I was talking earlier about, and I agree with Elle too, putting information out is great, but endorsing certain positions, we probably need to have an overarching policy about how we go about that. And so I think the discussion is valuable, but I also think that maybe what we need for us. It is some sort of draft policy to be looking at so that, because I think the consensus that I'm getting from the head nods and I don't, obviously can't see Ryan, but can see Raul, is that we all are kind of agreeing that we need a better overarching policy on what's going out. So I think if we had some sort of draft, and there's gotta be something out there that we could cheat on that we had hard copy to work with, I think that would be productive.
Madam Chair, I think too, we need to use the people in this room that know what they're doing. For specific items on policy, if we have a SCD or whatever, we need that person to come in and say, you know what? This policy CDC has doesn't really work for Idaho, or doesn't work for this case. I'm relying on their experience. I'm not a doctor. I have no idea how to handle some of this stuff. So, and that's always the way it's been on this board. Is they come to us, hey, we need to talk about this. We need to figure out how to solve it. And this is the solution. And listen to the experts. And maybe what we could do is put an item on the agenda every month to do a policy review or something that's come out, and then have those specific folks come in and tell us what they think we should do and what we shouldn't do. And then we could kind of design our own after that. But, you know, the issue, and I can see, I've seen this happen a lot in local government, is the fact that everybody's trying to cover their butt as far as liability. If we make a decision that kids can wear a mask in school, open it up, and then a bunch of kids get sick, they're gonna come after us. They're gonna come after us not only on social media, but liability wise too. And it's really made it hard to play in the gray area, so to speak. You have to have such specific rules just so that if this fails, they can't come back and sue us. And it's in everything, planning and zoning and all that stuff. And it's gotten to the point where there's a little bit of rule for everything. And we need to get back and live a little more gray area into our lives. Let us make some of those decisions ourselves based on what our experts recommend.
So but Madam Chair, I just have a question for Russ. When do you always put out guidance from the CDC under your signature, or yeah, I guess that's the question. Do you always put out guidance from the CDC under your signature?
Sure.
Yes, Russ, go ahead.
Raul, I actually don't put guidance out under my signature, other than if we do what we call a public health advisory, which is really a formal document. It's still an advisory, it's still a recommendation. So that's kind of that. We have 100 guidance documents out there, from STDs to wear your bicycle helmet, don't smoke. So then you have the advisories like we did for the harmful algal bloom on Cascade Reservoir, and that really is much more formal. The signature went on the orders of the board because I'm the secretary. So
so follow up, Madam Chair.
Yes, go ahead.
So when you sent out this guidance document and then you sent out a follow-up, they were both from your email, and they were very strongly worded. Is that what you usually do with guidance from the CDC?
Madam Chair?
Yes, Russ.
Typically, the guidance goes out from the agency through press releases, through social media, and through our website. That's how we push guidance out. We also have staff we call liaisons, like when I introduced Gina Pinnell as our new division administrator, she'd be working with the schools. So when CDC comes out with guidance and they say K through 12, mask up when indoors, regardless of vaccination status, then we're going to share that with our school administrators throughout our health district. That's how the process usually works. So just thinking on the kind of the timing on this, school, for example, when CDC pushes that guidance out, let's say it came out tomorrow, do you want, we'll work this out with policy in the process, we'll think through it and come back to you with some suggestions. It's kind of pointless to wait for 2 months when the schools are waiting. So the schools are going to react based on Boise School District, for example, is more likely to react based on what CDC says. So if the board wants to weigh in on that and say, no, we don't agree with that, and staff here said, no, we're not comfortable with that, we'll just have to figure out the kind of the cadence and meeting frequency and special meetings and things like that. Because that's part of the deal is we don't meet frequently enough. You meet 7 times a year typically to be able to respond to this. So absence of information, people are going to go to what information is published, which in this case would be published by the Centers for Disease Control, possibly by the Department of Health and Welfare. They typically adopt CDC guidance at some point in time. And again, some things are more important to be decided on in a timely fashion, certainly with the respiratory illness and what Lindsay shared with you and what Representative Langston shared. The hospitals are having trouble right now. We can't wait till October 15th to make those decisions. So we're going to give it some thought. We'll come up with a policy for you guys to consider that we think will be workable, but still be timely and efficient enough that we're actually having the impact that we want to have in the community.
Well, Madam Chair.
Yes, Megan.
And maybe that's where the compromise comes if you're talking about, Elt's comment about having local knowledge and authority versus repeating other people's data, right? So if I am understanding Raul right, the frustration is you took, just the collective, took CDC information and pushed it out as an endorsement. And that is different in my eyes from taking our perennial fight on plague in Elmore County and using our local experts. I just bring that up because I fight that every year. and taking our local experts and doing a press release that's localized with local, you see what I mean? I think those are 2 different things. And I think that, if I may, also ties in with my comment about taking a press release from a mayor and promoting that through Central District Health. That's where I think the policy statement needs to come, because it's one thing when you're taking our local experts and press releasing their information, and it's a different thing when you're taking somebody else's information and then pushing it forward as an endorsement. So I guess that, I think there's maybe a line there that you could find.
Any further comments, or is it the consensus of the board that we have Russ and staff work on a draft? Is that correct? Is that what I'm hearing? Yes. Draft of guidance.
Madam Chair, this is Commissioner Sturm.
Yes, Brian.
Hey, I just wanted to reply to Megan's comment and say, yes, I do agree with, I know you can't see me, but yes, I agree with both yourself and Raul and what you guys are talking about. I agree 100%. There definitely needs to be some kind of oversight on this situation.
Madam Chair,
Yes, Al.
Russ, are we going to shackle some of your people by doing this policy? I mean, I don't know how to say this correctly, but what I don't want to do is put out the wrong information. Because that's gonna, like I say, it's gonna destroy our credibility. To me, if one of your experts comes to us and say, we need to do this before our next meeting next month, to me, that's a concern. We need to get together again as a board on an emergency situation and come together and talk about that. I don't know about a policy that said, you know what, we need to vet everything that you guys are gonna put out. I don't think I wanna be in that position because we've been meeting every other day. So there's some things I think maybe perhaps this would be policy just for the coronavirus, not all the other aspects that we do as a health district. I don't, just throwing out ideas there. Because it seems to be the coronavirus is the thing that's everybody's stirred about. Nobody cares about. We're not going to say, shouldn't say that, but we have the STDs, we have all the other stuff handled pretty well, and I don't think we need to get into that policy. That's what I was trying to say.
Yes, Megan.
That's why I'm saying if you have an overarching policy that if it's local data, local statistics that you're press releasing, that's different than an endorsement And again, to your point, you don't want to look like a fool, and CDC hasn't exactly been great on, you know, the information that they've been putting out too. They've been contradictory and everything else. So I think that might be the line you can walk of not endorsing necessarily other people, you know, and more of a, this is a statement by Central District Health. Because, I mean, we just had the presentation on what the numbers look like and what the hospital data is. And if you want to do, as Raul mentioned earlier, promote vaccine use because they know that if you get the vaccine, you're much less likely to end up in the hospital. We have that data from the hospitals and it's transparent and you can see it. And it's one thing to release that as local data than it is to talk about double masking and all these other things that are kind of in the periphery. So I think that might be a line that you can walk as far as policy review.
Madam Chair,
Yes.
and if we could speak to the difference between guidance and recommendation, because to me, guidance is sharing information or expertise, but recommendation is implying that I think you ought to do an action.
Right.
Kind of, so I think making that differentiation as we're asking for this.
That's a really good point, Jane, because, you know, in the beginning, we talked about, when we started talking about mask mandates, and everybody missed the first part of the statement is that if you can't social distance, wear a mask. Everybody went right to, oh, I gotta wear a mask. We didn't sell that right, I guess, what I'm saying.
Russ? John, comment?
Sure, Madam Chair, so heard the discussion, appreciate it. I think I have a pretty good understanding of where the board would like to go, and we'll put together policy based on the conversation and bring that back to the board as a draft for consideration at the next board meeting, which is October 15th. 8:30, Friday.
Great idea, Raul, great idea.
Yes.
Thank you.
Okay, no further comments or discussions on this topic. We'll move forward. Going to have Laurel McMahon, our support division administrator, give our fiscal year 2021 financial report. Good morning. Good morning.
So this is my first in-person meeting this morning. Excited to be here, get the quick faces with everybody that I've seen on the screen for the past several months. And as we talk about how the budget ended up for the past year, I just want to touch just what I'm saying by reminding everyone that as we budget, there's always an element of prediction. This past year, that element of prediction was even stronger than it had been in past years in an unprecedented way. And Michelle Hanrahan here with me today, and she did a phenomenal job of doing a great work at prediction in unprecedented times when it required more prediction. So the first report that you have up on the screen today is our year-end summary report of our budget to actual numbers. As you can see, we ended fiscal year in a very comfortable position. Our total funding, as you can see under the minus 160%, was greater than we had budgeted. And then if you look at our total expenditures, they were right on budget at 100%. There's kind of an overall summary, what we'll get to in the next couple of slides, but stay on the slide for now, Dustin. Our undesignated cash balance at the end of the year, oh, you could go back one, sorry, Dustin, thank you. Undesignated cash balance was 2.4 million. Some of that's restricted funds. We'll talk about that when we get to the cash balance sheet. That is much higher than we normally are at that point of the year. Last year, if you recall, some of you may recall, we were at about 600,000. So much larger cash balance than normal. There are a couple of primary contributing factors to that I wanted to talk about. The main one was COVID changed the way we did business. We got in extra COVID funds. We did different activities in response to having those funds. So our operations, our staff expenditures were different than what we had planned. And it was hard to predict when we were going to get what funding streams. So we ended up with a large balance. Additionally, after we did the budget revision, there were several changes that we didn't anticipate. We'll talk about some of those things. We got in a couple of more grants than we had planned for, and then we also got in funds for the Mountain Home co-location project, which I'll talk about shortly as well. Looking more specifically at these numbers, so revenues, our fees were 14% over the budget in total. And for those, the service fees in both CEH and our family clinic services exceeded our budgeted amounts. Our total contracts were about 22% above what we had budgeted. And we did receive a new COVID vaccine outreach subgrant at the end of the year after the revision that contributed to that overage. Our other revenue was also over what was budgeted. You can see the huge overage up there where it says 580% in support services. And there's a very clear explanation on that. That is where we got about $75,000 from Health and Welfare in the very last days of June to pay for a remodel to our Mountain Home facility. Health and Welfare is now going to be co-locating with us in Mountain Home. They've begun that this week. Actually, on Tuesday, they moved in. Right now, they've moved in on an interim basis, but starting in next month, I believe they're going to start a remodel project to outfit the Mountain Home facility for more permanent co-location. So the good news on that is that community members in Mountain Home can now come in to our building and receive Department of Labor services, Health and Welfare services, and CDH services. So really cool project. We didn't know when the funding was going to come in, but it shows up there, that huge 580%. We, Madam Chair, just back up for a second. So we own the building. They're paying us rent, right? Yes.
Correct.
Okay, just to be clear. Yes, they're paying rent on an ongoing basis, and then they paid $75,000 for the cost of the remodel. Okay. Nothing is free for them. No. I want to make it clear. Yes, very clear. That's exactly right. And then county and state funding, continuing to look at the funding, we're right where we expected them to be. Our interest revenue was slightly lower than what we predicted. Reserve funding was right on budget, and that left us with a total funding overage of that 16% that's at the beginning. Looking at expenditures, see a little bit of a difference here year-end than some of the monthly reports that we had seen leading up to this. So personnel in both administration and support services were over what was budgeted. And that also had to do with the different charging cycle this year. So during the first half of the year, up through the budget revision, our administration and support services staff were charging almost all of their time to COVID. At the second half of the year, we began to charge back to normal activities, but we budgeted as if we continue to charge 100% of the time to COVID. So a little more than we planned through the budget revision. You can see that it all evens out in the bottom since administration and support services are a smaller division. So we end up with our personnel charges right at 102%. So pretty close to where we planned there. Our FCS and CEH personnel budgets were right on track, and then total personnel ended up at 102% of budget. Operating was at 91% at the end of the year. Most significant savings there were in administration and support services, and that's just that we had lower costs in admin, excuse me, forgot my water today, admin, PIO, and Board of Health costs. Capital outlay was right on budget, and then as you can see, our total expenditures. Okay. This is a little more detailed. This compares our year over year. So you can see that our fees were higher than the past 2 years leading up to this. What we anticipated as a continuing trend that we've seen throughout all of these budget to actual reports. That's for both family clinic services and CDH. And then in the contracts, you can see with that number, the $6,371,212, that's where we see the impact of the COVID funding. That's kind of the bucket. So much higher than normal. Contracts.
I have a question for you.
Yeah, sure.
Just real quick on the service, this is under the new septic permit fees.
This represents last year's fees, what they, oh, thank you. Last year's fees, yeah, through the end of June 30th, the new fees began July 1st.
And can you remind me again on the food programs, is that like after school stuff or is that big stuff?
That's the inspections for restaurants and food facilities.
Oh. Thank you.
And then the other column of this, you can see personnel costs are what we talked about.
102%, and then operating costs are under. So similar information, just a little bit of a different representation of it. And then we will move on to that June cash balance statement. Okay, and here we're going to see that much bigger number than we typically see. So the top of this. Got it. So top of this report shows that the total fiscal year end cash balance was $6,057,343. Reducing our cash balance by the total of the designated reserve funds leaves us that undesignated fiscal year end balance of the 2.4 million, so $2,430,591. Of that, $205,625 is restricted. And this leads into my next topic, which is going to be our reserve fund proposal and what we plan to do with that undesignated cash balance.
It's really good to see our operational reserve coming up.
It has come up significantly.
Madam Chair,
Yes, please.
can I also point out to anybody who's listening, this is our actual job around here. This is why we got appointed to the board. This is one of the primary reasons that we're here, is to review the budget and make spending decisions. And I think that people have forgotten that that is a function of the board when we start talking about COVID. So it is, I never thought I would say this, but it is lovely to review the financials. So thank you.
And so this, we will have an action item today, and open to any ideas that you might have for questions. Just a reminder on what our reserve fund policy says before we get started. After the close of the fiscal year, Board of Health assesses balance and then makes designations for the current fiscal year. So that's where we're at now. Our policy lists the 4 reserve fund designations. We've got our special projects and carryover projects. We'll talk a lot about that next. Our personnel reserve, which you're familiar with, to save funds for that 27th pay period that occurs about every 11 years. And then we've got our operational reserve for cash flow needs for emergencies. That's what we've been trying to get up to, that 3-month cash flow. And you'll see that we're there after this proposal. And then the capital reserve. And that's for major facility related costs in capital planning. If our AC or heating goes out or something like that, we've got this reserve set aside for emergencies like that. Okay, so the top of this slide shows our calculation of our available cash, and that's back to that big number, the $6,057,343, reduced by the cash on hand and our list of committed cash projects or programs, and you can see those up there in the very top of the screen. Deducting those obligations leaves us an available balance of $5.8 million. And then below that first blue line, you can see the proposed special projects and carryover designations. So we'll talk about that, all of those things individually. The top item there, the Boise office completion of the remodel, that's been on this list in that amount for some time. And we've talked as a board about when we plan to finish that. Our plan now is to kick that off about January. We still have much of our facility at capacity with staff right now. So as soon as we have a little more space and can move people around, we'll recommence that project. And we're thinking that'll be about January, hopefully, fingers crossed. And that'll be the carpet, paint, and a little bit of remaining furniture that we have to do there. So that amount hasn't changed. That's been that standing item for the past couple of years. The next thing on there is facility maintenance and service projects. We've got 200,000 there. And that is, sorry, I missed one. IT operating budget shortage is the next thing. So for our IT budget this year, it turns out we needed a little extra than we planned for at the beginning of the budget. We're doing a lot of things with IT, such as a conversion to Office 365. We're trying to do a lot with streamlining the public's experience with forms that they have available online, making it consistent, making their information access smoother and easier. So we're asking for an extra 200,000 for our IT budget to help streamline those things and then get some of our internal functioning where it needs to be with modernization. So
Well, does that include security too?
the IT budget does not include, oh, you mean IT security? Yes, it does. Absolutely does.
That's the big issue right now in government and stuff. security. There's a lot of hacking, a lot of stuff going on.
And we have several software programs right now that we use for our IT security, and we continue to have maintenance costs for those and new costs and upgrading of equipment, some of our hardware. One of our hardware for our IT security just came up with a renewal. And so, yeah, lots of things on that front that are constantly coming in.
I could see that budget going up probably every year.
I think so. I also anticipate over the next year that we might be able to streamline some of the software that we have, and where we might have 3 or 4 products for IT security. If we could get it down to 2 or 3 instead of 3 or 4, we'll be looking at some of that over the next year and hoping to either keep constant, maybe reduce, but yes, there's definitely a possibility it could continue to increase. Okay, third thing on that special project list is the facilities maintenance and service project. That's a $300,000 number. And that's just as things continue to come up for the facility. I know we've had some roofing damage recently. We haven't planned to replace the roofs on any of the buildings. We anticipate that that could happen over the next year. So we're asking to set aside $300,000 for that. And there's a couple of other facility type projects that have come up since the budget that we could set aside money for. So that's another ask. The next thing up there is a big ask. I like to describe that a little bit more. That's our indirect program costs stabilization due to COVID. So what we found as we did the year-end closeout last year was that our indirect rate came down by about 8%, came down significantly. And the reason for that was our administration and support services positions that normally go straight into the indirect rate and keep it at that about 34%. They were charging and doing work related to COVID. So they were charging straight to the COVID grants. So our indirect rate last year came down significantly, came down a full 8%. And normally, you know, there's fluctuations of 1% to 3%. It's unprecedented that we've seen that much of a drop in our indirect rate. We anticipate that this year there will be a lot less charging to COVID. We're already seeing that. We saw that with the personnel charges and admin and support services being over in the last half of the fiscal year. So we'd like to set aside, we're asking for $1 million to set aside for when that indirect rate stabilizes back to its normal levels. So I would suspect that this time next year when I'm talking to you about the indirect rate going back up, we will have needed to utilize that $1 million to keep it stable and to plan for what it will go back to after this year. Madam Chair.
Yes, Megan.
Question, is there, instead of taking it from now what is essentially county money, $1 million of county money, there's a lot sitting over in health and welfare. Can we take some of that ARPA money or COVID money or stuff that's sitting over there to supplant that $1 million? Is there an opportunity there? We are working on a proposal to ask for some ARPA funding. Right now, we do not have indirect cost stabilization included in that proposal. I don't know if that's a possibility or not. Because our charges were impacted by COVID, there's a possibility we could act for that or ask for that. The way that they've described how the ARPA funding can be spent, I'm not sure if that would be close enough to in alignment with it, but there's potential we could include that in our ask.
When I've seen, sorry, Madam Chairman, when I've seen the guidance, when it gets to public health, the guidance opens up substantially as compared to other impacts. So, and I don't know if necessarily you have to go to ARPA. I know they're still sitting on CARES funds too.
Okay.
But from the explanations that we have gotten even recently, when it comes to public health, it's fairly wide open for reimbursement as compared to trying to find certain lines to draw for things like infrastructure. So
That's a fantastic idea.
it would be, talking about my county, I would rather, if those federal funds are sitting out there and health and welfare is sitting on them, I'd rather take them away and not include the county with the.
I appreciate Megan's thought of that, Madam Chair. I think, do you think you're gonna need all that $1 million for that replacement?
So $1 million is about 8% of our budget.
Yeah,
So
that's a big chunk.
almost directly what the indirect rate went down. We don't know for sure that we will, but we don't want to be caught without enough. And I think this will be a year where we'll have to, you know, every month we do the carryover or
reserve fund report. I think this will be a year where we'll have to pay closer attention to that and look at all of these numbers. You know, are we using these special projects numbers that we've set aside? And that will be one that we'll probably have to monitor more frequently. We may have to do a quarterly reserve fund update if we need to, an action item on that.
Well, I guess honestly, what I'm thinking about is when Russ comes to the counties next year, and the counties are funding all this, you've got to be able to say, this is what this $1 million did. The counties are gonna be, I need to see a breakdown of what you guys are actually wanting to do with that money. If it's support services, it's clinical, whatever it is, we're short because of COVID, or, you know, why didn't, like Megan said, why didn't you go to the state and see if they had any COVID funds to replace that instead of, those are the things you're gonna have to sell in that budget. It's gonna be tougher. Especially if our economy starts going backwards, then it's gonna get really tough.
That's like say for $1 million.
Yeah, well, 10% of your budget, that's a lot. 9% or 8%, that's a big hole.
Should I see that Michelle?
Yes, Michelle. Yes, Madam Chair. I just wanted to speak to what Megan mentioned about the federal funds. The CARES Act didn't allow us to get reimbursed any indirect costs. So I know that's not an option to get funding from the CARES Act for.
But they've done their guidance. The guidance keeps changing and opening.
Okay, we can look into that. Yeah, that's the direction they've been giving us. And
Some of
the
ARPA too.
health and welfare does have other COVID funding that they have shared with us, and they continue to give us more. But we have to, the people that are coding to that federal grant have to be doing the work that is related to that federal grant, so our support service staff can't code there if they're not actually doing COVID work, so.
They charge the money.
Yeah.
Our county got a little over $2 million, but we can't spend it yet because they haven't really come out with the guidelines for ARPA. It's coming, I think, in September. But I think there's stuff in ARPA too that would cover some of this.
Do you want the ARPA guidance that I got? 'Cause
Sure.
We got a.
That's what all the counties are waiting for. IEC would probably use it before we would, because they're the ones that are going to disseminate that.
So just, if I may, Madam Chair, the ARPA guidance, so we just had a meeting 2 weeks ago where Legislative Services put together a booklet of what ARPA guidance looks like right now. And it's not finalized. And like I say, it keeps changing, and we're starting to hear more on the COVID funding that still exists because we're in a unique position that we haven't been able to spend it like other states have that had economic declines. So we have this huge influx of cash, and the guidelines initially were to supplant funds from states that, like California, essentially, blue state bailout. And so I know that the guidelines have been shifted and exemptions have been made just because of the inability to spend the funds. So that's why I bring it up. But if you want to take a look at that booklet, I'd be happy to send it to you.
I think that would be great as far as the counties are concerned, at least in our county. We thought all the coronavirus money was gone. It's nothing left. So we've been paying that out of our general fund. Let's continue on. I think
Sorry.
you know where we're coming from.
Yeah, thank you. Thank you for the suggestion. The next two items in the special projects list are an FCS, so Family Quick Services marketing campaign, and then environmental health system upgrades. And those are both really related to our clients and the client experience. For the first, we'd really like to continue to grow our clinic and promote the services offered there. And then the second is going to be used to enhance the environmental health systems that we use for inspections. So some of them right now, they're doing on tablets, they're doing electronically. The system that they're using to do that is old. We'd like to be able to have some funds available to upgrade the system and then make sure that all our childcare inspections, all of them, we're able to do those electronically. So those are both.
And Laurel, if I may suggest, because we're doing the same thing throughout county government, the big cost of the IT upgrades on a lot of this stuff is storage, data storage. And I mean, it's very expensive. So make sure you guys look into who's going to store it, because in counties, we have to store it for 10 years. So we're buying $90,000 servers just to store this information for 10 years. It's not on a network, it's not accessible, it can be hacked. And it's the storage that costs the money. Probably the biggest cost right now is body cameras for sheriff's departments. You have to store that for 10 years, and that's a lot of data. So keep that in mind when you guys are upgrading.
Thank you, good suggestion. Yeah, we have different requirements for storage, 3 years, 5 years, and then some things we keep in perpetuity. So some things don't go away, so we do always have to account for cost for where that's gonna live and how it's gonna live there. So thank you for that point. And then the next one up there, facility modernizations, Boise McCall Mountain Home, that's $50,000. There's a new monument sign that we'll be adding to the Mountain Home facility. And then just signage within the buildings to make sure that when customers come in, they have the same experience. So if you walk in to the Armstrong building, to the Mountain Home building, or the McCall building, it looks the same to you. You're seeing the same types of things. In Mountain Home now, we're going to have health and welfare staff working side by side with us. So we want to all of our working spaces to be clearly marked with who you're going to and for what services. So that's all included in that. The next thing up there is, or the next two things actually, the CDH grant writer for environmental health and FCS. That position is a new position that the grant writer will be specifically seeking out funding opportunities to apply for grants to expand the services we offer to our district. So we're looking forward to being able to bring on that new position and continue to grow what we offer to our community. And then the last thing up there, that health policy and promotion admin assistant, a half FTE. That's an admin assistant to help process those grants as they do come in, help us track them. And it's just half of the FTE, the other half of the FTE will be paid for by existing resources. And that's a support position that we've needed for a while. We've been managing the work with the staff that we do have, but we think that will help a lot with the continued growth that we're seeing across the agency.
Yes, Megan, but there's a little bit of shudder in me that I'm about to ask this question. For Family and Clinical Services Marketing Campaign for Clinic Growth, we have always made a point of not competing with free market systems. So how are you going to make sure that those promotional materials are not competing? And this is where I'm going to shudder here for things like primary health.
Sure.
Yes.
Yes, Rose, go ahead.
So we offer a lot of services that are not offered in the broader community. In fact, when it comes to things like primary health, if somebody's coming to us for our other types of services, and as everybody knows, we have a sliding fee scale that slides to 0. So I would suggest that we be directly competing. You think about WIC, and I'll just use that as an example. Nobody else offers WIC. We serve about 7,000 individual clients per month, but the data that we have suggests that there's twice that many families out there that could benefit from the services. And again, we believe in the importance of nutrition education, breastfeeding, promotion, and support, and that starts the first trimester of pregnancy if we can get people enrolled. So we have some really big gaps. That'll create opportunities. Home visiting is another one, building that community, the knowledge out there, and a lot of it's working with primary care providers that see young families or provide OB care. So point well taken, or it's not our intent to put our signs up beside primary health medical groups, billboards on State Street, but rather strategically focus on the community that we see as our primary focus.
Madam Chair, I have 2 questions.
Yes, Al.
And I think, Megan, a lot of it to me is like the Parents as Teachers program. I think that one should be expanded big time. I think that's a very beneficial program. The other question that I have for you is, do you expect an increase in refugees since what's going on in Afghanistan? Is there going to be a big influx coming in here the next month or so into Boise, and somebody's got to help those folks, right?
Madam Chair, I do. I think, right, the national policy has shifted with the change of administration. And as you pointed out, there's always war-torn areas all over the world, but definitely with Afghanistan and some of the impact there, I think we will. We do serve those families. We You know, others provide primary care, but we're very involved with some of our other services, childhood vaccines, and WIC is another one. A
What
lot of
about
these-
the teeth, the kids?
Oral health.
That's all in this too, isn't it?
Correct. So we have our First Teeth Matter program. That's a really close partnership with WIC and helping, you know, and back to Representative Blank's comment about competing is these are little kids that aren't getting into oral health. Their dentists don't see children that don't have insurance or who are, many don't see children who are on Medicaid. And our goal is by the time they head off to school, they don't have a mouthful of tooth decay and all the surgeries and complexities that happen. So, you know, our mission is partnering, not competing, to promote that health in our community. So we take that mission very seriously, and this will give us an opportunity to step up that game a bit.
And Madam Chair, maybe this is some of the things we need to look at when we policy. Things that we do that don't compete.
Right.
You know, that kind of thing. I also had another question for Laurel on the grant writer. So we don't have a grant writer now.
We do not. We have staff that do that in addition to the regular duties. But this would give us one focus position that would do that.
My only advice or recommendation is take your time hiring a grant writer, go through a lot of apps and look at their experience. County hired one 2 years ago and we've already pulled in close to $1 million. More than pays your way. It's a good investment. Just make sure you get a good one when you hire.
They have any interest in moving to Boise?
No, I'm not gonna mention it to her. Actually, right now, we're trying to find her house to live in. You know, living in the fifth well, a year and a half. We don't wanna lose her.
I wouldn't give out more information, or else I'm gonna be knocking on the door of the fifth wheel.
I know we had a lot of applicants, but a lot of them had never really written grants. They wanted to learn the job as they went. It's like, no, we need somebody that's ready to go. And 99% of the time she works from home. She doesn't even need an office.
Do not even get onto that fifth wheel, just driving her down.
But they're definitely worth working.
Okay, and then the proposed FY '22 reserve fund designations, these are our typical reserve funds here. So the personnel reserve fund proposal is to increase by 17,000. That gets the reserve fund where it needs to be for that extra pay period. The operational reserve fund is increased by $306,700, which brings us to the total there of $3,176,000. And that puts us right at that 3-month cash flow target that we've been working towards since before my time. So, alluded to that earlier, but that is that goal of where we want to be. And then finally, the capital reserve fund is proposed to increase by 50,000, which brings us to the 500 that you see on the screen. And that allows us to plan for those future capital needs or any emergency situations that.
And those are the kind of things that county commissioners look at. Where are you gonna spend $500 grand? How come you have that much in your budget? It's been sitting there for 2 years. So those are the kind of questions you.
I'm doing the same thing you are, and then that leads me to the next question of why do we need to put in $1 million for stabilization? Because we can show cost savings going forward by not putting into the 27th pay period and the operational reserve. So.
And we could change the designations. That million for the indirect funding stabilization is just because we know the numbers were off and we know they're gonna recenter. We know they're gonna go back to what they've always been, and this lets us plan for that. If you choose to move the funding around so that it's not the million in the direct funding, we may have to take from some of the other operational or some of the other reserve funds at the end of next year when it does stabilize again. So how we designate it now, bottom line is we have the 2.4 million extra. We know we're indirect. Dropped by 8%.
You never want to say extra. Let me just tell you that right now.
We have 2.4 million in our undesignated cash balance. And here's the designations that we think are most fitting going forward. If we need to move them around, that's at the discretion of the board to do so.
And just for your information, Laurel, most counties have a general fund reserve for the emergency stuff. And ours is 350,000 for the whole county. So your $1 million and some of this other stuff is pretty flush.
It is.
Madam Chair.
Yes, Russ.
So this, Laurel reviewed that at the start, not been pulled up on the screen, but there is a policy that was set by the board, so that's what we're following. And the operational reserve, that really big number is been out there. Legislative Services Office said this is what you need to have. So that's what we brought to the board. You guys set the policy. If you want to change that, we certainly can.
No, and I'm really excited about the 27-pay period because that was a big, hard thing to get through for us, and now we're preparing for it next time. So I'm glad everything's going pretty good.
So, that's the summary of the request for the expenditures and reserve fund designations. Ask for the board's approval on these items.
Okay, thank you, Laurel. We do need a motion to approve that, so,
Madam Chair,
yes.
I still feel uncomfortable with the cost, the million in cost stabilization. I mean, I don't feel good about that. I just want it known.
Well, the only way we could do it is if we found some other funds to cover it.
Well, that's why I guess I would suggest just put it in the undesignated for now, rather than designating it for that.
Or maybe put it in an operation reserve fund or something like that.
Yeah,
Increase that and leave that indirect cost out completely. I don't know, it's whatever you guys want to do, but $4 million plus reserve fund is pretty sweet. If you guys could find extra money, we can't go back and change this. If we approve this, we can lower it, but we can't raise it, right? What do you want to do? What do you feel like?
Madam Chair.
Go ahead.
My recommendation, I mean, Laurel and I talked about this, it's not ideal to have $1 million sitting out there for budget stabilization. And the correct term is, this is indirect cost that we're going to almost certainly incur if the indirect positions don't continue to charge, which we're not, at nearly the same rate as we did last year. What that did was that me included charged a lot of my time to COVID. So that essentially is what Laurel described. It reduced that indirect rate, and then we built our budget based on what we knew. That's what we have to do. Now the question is, where will we end up at the end of the year? So if you wanted to move it into the operational reserve fund, of course, it bumps it up beyond the 3 months then. And then at some future board meeting, we could do it in February, when we do our budget revision. We can always bring this up. This is the time of year where our fiscal year ends June 30th. We end up see where we're at with cash. The designation discussions take place, which just happened. We can make adjustments later on. I mean, I guess the money's there, whether we call it indirect or whether we move it into operational reserve. It's almost certainly going to be needed. That's for sure.
but I'm sure. Go ahead. I do find some irony in the fact that we just had a presentation that says that COVID is coming back, but you're saying that you're not going to charge to COVID anymore. I just point out the irony there.
Sure.
Yes, Rob.
That's a great point. And there is a great deal of uncertainty as to how this year will play out. So, right, a budget is a plan. This is the plan, and it definitely could change. Example, if I start charging a lot more of my time to COVID, once again, the indirect rate will be lowered and we'll have that federal money coming in. Or if we're successful, to your suggestion of getting ARPA funds through DHW, we'll bring this back to you. This is a plan. This will be the plan going forward if you approve it, and we can certainly make adjustments anytime down the road.
Particularly.
Make the motion that we move the indirect program cost of $1 million down into operations.
Any further discussion? Okay, starting with Ada County, Mr. Labrador? Okay, Dr. Young,
Jane Young, aye.
Elmore County,
Megan Blank's aye.
Boise County Commissioner Stern. Are you there, Ryan?
Yes, Commissioner Sturb, aye.
Thank you. Valley County.
Mr. Hasbrook, aye.
Okay, thank you. Motion passes as stated, so.
And sorry, this is Raul Labrador. It passed, but I'm also an aye. I apologize. My mute button was not working on mute button.
Okay, thank you. Thank you so much. Let's see, Laurel and you, does that include everything?
Just I have one additional, the July month-end budget. This looks similar, but instead of the end of the year report, this is through the end of July 2021. So 8.33% of the year completed. And as you know, at this point in the year, it's hard to tell how things are going. So we just have a few numbers to look at so far. Our revenues right now are at 12% of budget, expenditures are at 7% of the budget. There's just a few things to mention here. Fees and contracts are on track. CDH contracts are slightly high due to billing in July for June expenditures. Other revenue is high because we received the Millennium Fund and CRP funds in July. Home visitation funds should arrive in August, so sometime this month, in the next couple of weeks. And then expenditures, just brief summary there, personnel, operating, and capital are all right about where we expect them to be for this point in the fiscal year. Page 2 of this presentation shows that everything's on track as planned for the first month. Fees are a little lower in CEH than this time last year and a little higher in SCS, but again, we're so early in the year that it's hard to tell what that means for trend data, and we're still pretty close to where we expect to be. Personnel and operating are on track, and we haven't spent anything so far for capital outlay. And then cash balance on page 3 will be some updates to this after the regular plan changes are put into it, but total cash balance was almost 6.7 million at the end of July. That balance is high because of the state funds we receive in July. So that's the difference between what it was at the end of June and what it was at the end of July. And then you can see the large undesignated cash balance there, and that's because we hadn't approved what those special projects and reserve fund designation changes would be. At the end of next month, you'll see the changes to that were just.
Madam Chair, just a quick question. Russ, are we going to have a report later on the mental health board and how that board is working? Is that still, I don't see it on the agenda.
No, we have planned to do that. We can.
Maybe next month we can put that on the agenda and have a discussion about that. I understand. Just kind of sliding going on there, so.
So that summarizes.
Right on.
Yeah. Okay, thank you, Laurel.
Thank you, Madam Chair.
Yes, please.
Do you think we could take just like a 5-minute break?
Well, actually, I was gonna ask, Justin, can you hear me?
Yep.
Okay, at this time, I would like to take a 15-minute break, and so we will reconvene well, let's make it, we will reconvene
They break it down by all the different categories. They do.
Actually, what's happening is Seth and I see.
Yeah.
It's really putting together a new program.
Good.
Thing that we learned, it's shovel-ready stuff.
We're live.
We're live?
Yes.
We're live? Okay, thank you, Dustin. Okay, next on our agenda is the review of our vaccine status and distribution by Natalie Rosine, our public health preparedness program manager. Thank you, Natalie.
Thank you, Madam Chair. Good morning again to the Board of Health. Just going to provide a quick review on our vaccine planning and distribution, some of the activities and the vaccination rates over the last couple of months since we met last in May. Next slide, please. So again, just a quick review of the process as to when we started and what that looked like and kind of what we are doing now, because that has changed some. So to go way back to the beginning, our vaccine allocation and administration began in Idaho mid-December of last year. So we are just about 8 months in of having vaccine in our state and having that administered throughout our jurisdiction. And in the beginning, the public health districts would receive a weekly allocation of doses and type of vaccine from the state immunization program. And we would then work with a list of enrolled COVID vaccine providers in our jurisdiction to see what their needs were and then to direct ship that vaccine to their specific location. And at the height of enrollment in COVID providers, we had over 135, 140 total enrolled vaccine providers. So again, we had a lot of coverage in that kind of decentralized approach that we're able to get vaccine out across our jurisdiction and into those different providers' hands. And in the first 5 months of vaccine administration, Central District Health was able to allocate all of the doses that were made available to our jurisdiction from the state immunization program. And that was in the time of really high demand for the vaccine and low inventory. So we're really we didn't have enough vaccine to go around for everybody, and there was still high demand for the vaccine. So we saw a bit of a shift. So towards the end of April, that shifted. Demand for the vaccine started to go down pretty drastically. And there was plenty of vaccine inventory out there with our providers. So at that point, towards the end of April, we were not able to allocate the total number of doses available to our jurisdiction out to our providers. They had plenty on hand and not enough people coming in to get that vaccine. And then beginning the end of June, so the week of June 27th, our process changed a little bit. And how we received vaccine into our jurisdiction and how that was allocated out to our providers. So at that time, there was no longer a weekly direct allocation to the public health districts from the state. And providers would just request vaccine as needed. And we would then either order that if a new order of vaccine needed to be placed from the state to the federal allocation. Or we would first try to redistribute vaccine from provider to provider. So if our provider came to us and said we would like, 100 doses of Moderna, we would then work with the state immunization program to see if there were other providers within our jurisdiction that had that in their inventory and were willing to redistribute that. So again, the process changed a little bit, but still working very well. There's still plenty of inventory out there. We have certainly seen a little bit of an uptick in vaccine order requests from our providers over the last week or so. So we're seeing that demand go up. I think there's a lot of activity with schools coming back online. And then also the new recommendation from the FDA around third doses for immunocompromised people. So
Yeah, excuse me, how much did that take us? Pretty strong.
I would say it's pretty significant. I mean, there were some weeks there that we would get an order or two maybe from providers that needed vaccine. And I think just this week, I probably put in 6 or 7 orders. And one of our larger health systems placed one of the biggest orders we have ever placed for Moderna and Pfizer to cover their systems.
Yeah. Awesome.
Yep. So good news on that front. Next slide, please.
So just wanted to touch base on some ongoing vaccination efforts in our jurisdiction, and this is not an exhaustive list. There are a lot of activities and events and collaborations that are going on around our jurisdiction for vaccine. But of course, we do have providers now that have shifted from that appointment-based clinic to walk-in appointments, and then also having inventory on hand and made available to their patients when they're coming in just for their regular medical appointments, which is great. And when I'm talking about providers, I'm talking about hospitals, outpatient clinics, family medicine, pediatricians, pharmacies, federally qualified health centers at QHCs, FMRI, and Desert Sage. And then, of course, here at Central District Health, we do offer vaccine as well. So a lot of options for people to go if they are seeking out COVID vaccine. And then the second bullet point here, which is pretty exciting, is we have a mobile vaccine provider group that we work with that meets regularly. And this is a group of vaccine providers that have current mobile capability. They can go on site, maybe to a workplace or to an event, and offer vaccines. So typically, we will hear from an event or in a location or maybe even a business that will come to us and say we are interested in offering vaccine at our and then we would simply work with this mobile vaccine provider group to kind of match them up, provide that opportunity to this group who has availability, and then we could set up these kind of non-traditional clinics so these things are happening. And of course, we're hearing a lot. There's a lot of events that happen in our jurisdiction. So vaccine has been made available with the provider of the Twilight Criterium. The Egyptian Theater vaccination location is open right now, and that will be open through Tree Fort, which is great. We have a number of providers who are kind of rotating there. The Lowman Fire and EMS clinics, we have a provider that is going to be doing a vaccine clinic up in the Lowman area. Western Idaho Fair, Cathedral, the Rockies, and the list goes on and on. So we do have a calendar that's located on our website at cdh.idaho.gov where a lot of those events are listed. So go out there and take a look at that. And then the last thing to mention is homebound clinics. I think this is really important that we continue to be able to offer this. We do have a provider that has that mobile capability that has been working with those that are medically homebound or those that have mobility and accessibility issues. So if we have, say, someone calls into our call center that is not able to get out to their doctor or to maybe an event to get a vaccine, we can again match them up with this provider and get them where they can get vaccine in their home. So a really important program there.
Yes. Quick deal, we have one cat. Well, super seniors elderly, and I think there's a good person there that if they knew that, hey, we could send somebody out to give you a shot, I think that would be very successful.
Okay, great.
But I don't know if that homebound clinics in Valley County, I don't know if they're up there yet.
I think we would certainly present that to them. They would probably go. So really great partners.
Good. You guys are using them. That's good.
Yep. Next slide, please. So we'll shift a little bit to our vaccination data. So where are we at right now? So the last time we met was back in May, so provided some vaccination rate data there. And I am pulling this information from the Idaho Department of Health and Welfare Vaccine Data Dashboard. So this is something that is managed by Health and Welfare, and this data is coming out of IRIS, which is the Immunization Reminder Information System.
Supposed to be used for children.
This data is updated Monday through Friday after 1 p.m. So the data that I was able to pull for this presentation is current through the end of day on the 17th, which is Tuesday. So taking a look at this is kind of a big look at the 7 different health districts across the state. We, of course, are right smack in the middle, Health District 4, and we are leading the state, I have to say, with 61% fully vaccinated. So you'll see there's a dark green bar and a light green bar. The dark green bar shows percent fully vaccinated. We are at 56% for our district covering our 4 counties. And that is just over 256,000 persons. The light green bar shows percent of those that have received at least 1 dose in that 2-dose series. So we are at 5% for Health District 4, and that is about 20,500 persons in that bar. Next slide, please. So this breaks it down just a little bit more, taking a look at vaccination rates by county. Again, the data is current through the end of day on Tuesday. Again, we are right in the middle of our 4 counties, Health District 4 there. So Ada County is sitting at 63% and second only behind Blaine County, which is up in the 80s, and they traditionally have been the highest county. We have been number 2 and number 3 with Valley County right behind at 62%.
Just get Elmore to do something.
We are. You're gonna skew your data.
Yes, and then Boise, I should say Boise County is sitting around 30% and Elmore County at 36%. But again, this is data that's coming out of the IRIS system. So all those, people that are out at Mountain Home Air Force Base are not being counted in this vaccination rate. And I did receive some information from Lindsay with our EPI program. But as of the end of July, so July 28th, the base was reporting 61% vaccination rate. So this number, obviously, if you're taking a look at that totality with those that are on base and those the numbers in IRIS, it's going to be much higher than your 36% in Elmore County.
Madam Chair, this is a quick question. When did the vaccines come out here? It's like January?
Mid-December, December 14th.
Be 2 years this December.
1 year.
So in 1 year, we've got over half our district vaccinated.
Yeah, in about 8 months.
That's pretty phenomenal, I think. So we'd be proud.
Yeah, again, we have unbelievable partners and providers all throughout our jurisdiction that have been really great to work with. Next slide, please. So this is the final slide, again, kind of taking another deeper dive into the vaccine data. So this is looking at the different age bands for our jurisdiction. So this is just our 4-county area. Again, on that number on the far right bottom is showing 56%, and this is fully vaccinated. That's not including that 5% that have received at least 1 dose in a 2-dose series. So 56% complete vaccination rate for ages 12 plus years and older. And you'll see here that age 65 plus is our highest grouping for vaccination rates. But they also became eligible for vaccine February 1st. So they've had the opportunity to receive it for much longer. If you're taking a look at our 12 to 15-year-olds, which is sitting at 30%, that's slowly but surely continues to go up over time. But Pfizer is the only vaccine that is approved for the 12 to 15-year-olds, and that was approved by the FDA on May 10th. So just a few months eligibility for that. Slide. This is my last slide. Yeah, so just again wanted to provide some information resources, different websites. Again, kudos to our public information team for having all the information available. We do still have our call center operational Monday through Friday from 10 a.m. to 2 p.m. And they are a wonderful resource for answering all kinds of questions, even beyond COVID. So is there 208-321-2222. And that is the end of my presentation. I'll stand for any questions.
So thank you so much.
Thank you.
Okay, next is our review of the CDH social media by Trustee, our public relations officer. All right.
Madam Chair, thank you. Board of Health members, appreciate your time today. I will try to keep it pretty brief. I know you have a pretty hefty agenda here yet. Before I get started, I do want to point out who else is in the room with us. We have Alina Gilmore sitting at the back table with Donna. Alina is a public information technician here at Central District Health, and she really has kind of that day-to-day obligation to oversee our social media accounts. And it's a big job. We collaborate a lot on what to post, when to post, but definitely want to give her great credit for the work that she does. Her job extends well beyond social media. So glad to have her in the room with us today. So let's dive right in. We're going to talk a little bit about what we do, why we do it, and how we do it. Here are the platforms that we are currently on as far as social media. Facebook's been around since 2004. We've been on it, I believe, since 2008 or 9. That's the platform that allows you to post pictures and videos and text. Pretty flexible in terms of how much you can post content-wise. Twitter is the one that's a little more limiting. That allows you 280 characters in a post. You can also post pictures and links and whatnot. Instagram is a little bit more limiting. It's more of that image-based platform, and it's a newer platform for us. We just, I think, started an account about a year ago. And then YouTube, of course, people might not think of that as much as a social media platform, but it's the platform that we use to broadcast these meetings. We also post educational videos, PSAs. We've also streamed COVID-related vaccine sessions and information sessions through YouTube. So it's been a really valuable engagement tool with the public. So why do we use social media? We're a government organization and we have a lot on our plate. It is a great opportunity to engage with citizens. It gives us an opportunity to put faces with our agency name and brand. We strengthen relationships and we can educate our communities. Certainly, it's been a critical tool with COVID, but beyond that, it's a very important tool that a lot of our team members rely on as well. We frequently get requests from a variety of team members to post content. So we work hard to try to balance that and provide opportunities to get other public health messages in there right now. As I mentioned, crisis communications with COVID, it has been critical. We also use it to monitor happenings. It's kind of a good one-stop shop. You can hop on Twitter really quickly. We can see what kind of conversation is happening about us as an organization, see what's kind of trending, be able to respond to comments and questions as they come up. So it is very valuable. Again, building that trust with the folks who follow us in our communities. And we know that people really like to see pictures. Outside of COVID, we're doing more posts that involved our staff and pictures of our staff, and those tended to be really high engagement. So, and whether that's, people's families following our page or former employees, but we know that people do like to see faces and associate it with our agency. A few more reasons. It's timely. It's really quick. We are a team of 2 people, and it's a lot easier to push out social media messages than it is to write a news release. Of course, it's a tool that we often use in conjunction with other communication tools, our website, as Russ talked about earlier, and news releases and things of that nature. It can be free, or we can pay to boost posts or target specific demographics. Typically, we only do that when we have very specific funding sources that allow us to do that. We have been doing some paid social media posts through grants that we've received regarding COVID vaccine acceptance, and those have been doing pretty well. We've done one in Spanish to Elmore County, Boise County, and I believe we've done some in Valley County as well. So that's a great advantage. It's typically free. And really, it's our duty. People have an expectation that we will post content and be transparent. We post information about these meetings, post links to let folks know that they can send you all comments. So it is our duty, and people look to our Facebook pages and our Twitter page to kind of see what is the most current content and information that we are sharing. So moving on to what do we post? We kind of have a 2-pronged approach, and that is posting our own content that we create. Lena and myself, we meet every Monday. We talk about kind of what is ahead for that week. What do we think our messaging needs might be? We can't always predict that. So a lot of the time we have to kind of roll with it throughout the week and kind of have that reactionary response and respond to what's happening within the week. Let's see. So we post news releases. We make weekly graphics related to COVID. You see up there kind of toward the middle, kind of our county vaccination rates. We want to share those with the public. We queue up every week a graphic that says kind of bite-sized pieces of what to know about COVID this week to keep people in touch with what's happening within our jurisdiction. We also post videos, timely information or pieces to educate. For instance, with the recent Board of Health appointment for the physician position for the board, there was a lot of questions about that and what that process looked like. We were getting a lot of media questions. There was a lot of social media chatter about who was involved in that, who's the decision-making body. So what we did is we created a series of slides on the far left there, I guess my left, broke those up into kind of the steps and shared that on our website, on our social media, and then Ada County shared those slides through their social media platforms as well. So the other piece of this is sharing other people's content, and it is really pretty critical that we do this. It's somewhat of a we scratch your back, you scratch ours kind of relationship. We have a limited number of followers on all of our social media platforms, and certainly those people do not see every post every time that we put out there. So we really rely on those partnerships with community partners to share our content, and we want to do the same. And really, social media, the best practices are that you're sharing your own stuff and you're sharing others. You get much more mileage. And how we do that, we consider the source. Who's posting the content? What is their level of credibility? And then what content are they posting? Is it under the umbrella of public health? And we know that public health touches a lot of different parts of life, right? Health and safety and wellness. And so we try to use those as kind of our guardrails of sorts in terms of what we post. We want things to be relevant. And again, sharing that content of others broadens their reach as well as ours.
This is, Madam Chair, where I want to call it screeching halt.
Sure.
To this.
Go ahead.
Okay. I appreciate the original content that comes out of Central District Health. Appreciate that. That's great stuff. Love it. I do not appreciate what's getting shared because it doesn't always comply with some of the messaging that comes from this board. And the one that really ticked me off, and I would like to know what the procedure is, how it gets approved, who's in charge, is why are we reposting the mayor of Boise? That is not a community partner. That is a political figure, and we shouldn't be getting involved in that. And I am not naive on how this all works. This is part of my job, so let's not get in the splainer mode of it. But we should, part of the problem that we have with credibility is getting involved in political issues. We've seen it with commissioner appointments. We've seen it with reposting the CDC information. That's why I say original content, fantastic, because we have to own our original content, but I don't like owning other people's content. And when you share stuff, you're owning their content. And it's different if it's a community partner, somebody we've worked with. I was just scrolling through, I wanted to double check, see what the latest stuff was that came up. One is something that you guys have partnered with to do the capital steps. I have my own opinions about that, I'll keep them to myself. But I think that there needs to be a brighter line over what is appropriate to share. Because I can guarantee you that the thoughts, philosophies, and principles of Elmore County residents do not align with the thoughts, philosophies, and principles of the mayor of the city of Boise. And to somehow give an endorsement of her thoughts through what is a conglomeration of counties, I find to be really inappropriate. And this is my time, this is the only time where I can say it in public, but I think that there needs to be a review of how these decisions are made and what gets shared. And it needs to be more strictly adhered to, in my opinion, to our community partners, not reaching out and finding other content and sharing it. Because whoever is reposting stuff and sharing it,
you're making me own it. And that's not right if it doesn't align to the policy of the board. So I guess I would like to see the decision chart on how this comes about and how that works. Again, original content, awesome, love it. This sharing in this particular organization is very touchy. It's not the same as if I go on my personal Facebook page or my Instagram or my Twitter account and start sharing other people's stuff. My name's on it, I made the choice, but when you guys are sharing stuff, you're making all of us own it. And it's obviously, I feel pretty passionate about this and I'm concerned about it. Yes, go ahead.
So based on what Representative Flangsman brought up, I think we do need to have a discussion at some point, not today necessarily, but in October. You know, what Christine had described, you can see your food bank, mosquito abatement. That's how social media works, right? You share content. I get what content is, but what I would strongly prefer is we don't just limit it only to our content, because then other people won't share our content, and then as Christine described, our reach becomes extremely narrow. So if it's more got the message, we talked about it, is that if it's not sharing content that's specific to Mayor McLean, if the city of Boise as a city, or city of Star, or city of Glens Ferry pushes something out about fun run coming up and we want to repost that, I mean, where is the line drawn? If it's a political statement or a position of a particular elected official, I get it, but I also, I made the point that if we just only post our content, don't post content of others, then our reach just goes from this big to this big. So just, and again, I think it needs to be a discussion among the board. You heard Representative Flangsman's opinion.
Well, and I think that's fair, and I don't think that's what I said either, was just content. I like buying with community partners. Okay, get that. But the mayor of the city of Boise is not a quote unquote community partner. And when you look at the CDC, which is putting out conflicting information, it seems like almost on a weekly basis. And this is also to Raul's point of, you know, we're then having to own this kind of information that isn't being generated within the building. So if what we're doing is sharing things that are our community partners, then I think that's great and it's completely appropriate. It's just we start crossing a line when it's not a community partner, and that's my concern. And because you don't, I mean, you go ahead and look at some of the comments on some of these posts. I mean, there's one gentleman, as I'm scrolling through, who posts regularly to defund it, right? And so there's, I think that there needs to be a better policy on what is happening, because you don't need to encourage that kind of interaction. And I appreciate wanting to have a reach, and I appreciate wanting to promote Central District Health policies. But as soon as you start going down the other end and it becomes political, it cuts into your own credibility, and then it limits our ability to disperse proper information.
Sure.
Yes, Russ.
Follow-up question. So what I heard you say is if it's a post from an elected official, in this case, we should not be reposting that content, even if it's 100% public health, but if it comes from the county or the city, we look at our cities and we look at our counties as partners, certainly. But I'm just wanted to be clear, and I want to be clear that it's the board's preference. If it's Mayor McLean posting it or Mayor Chadwick from Star, your preference is we should not repost that content no matter what it is. But if it comes from under the city logo or from the city marketing media person, then that's okay to post, as long as that's appropriate, just like we have up here.
I'm sure. I think that's, you know, there's going to be some gray area there. But I mean, I guess to use that example,
I didn't see us reposting, you know, my content when I am running public health bills. You know, and I run several. And I think to the improvement of the function, but it's not appropriate. It's not appropriate for Central District Health to be reposting essentially a politician's position on something. And that's, obviously, it made me really frustrated.
It's gonna be really tough, but I think it can be done. But I give Christine the credit for this conversation and understanding where things coming from. What I don't wanna get to is the point where they got to call us every time.
No, I'm not indicating that at all. That's not what I'm saying.
We can put a disclaimer on some of that, or I don't know how. Facebook, I went on that book for about nothing. However, I will say that we have terminated, I believe, 2 employees because. Can't come back on the employees. Careful what you say about bosses. Still.
Well, I'm sure, I just think this partners what we're talking about. If we're gonna set an overarching policy, we need to make sure that that policy flows through everything, all of the information that is dispersed. And you don't want someone else's opinions, thoughts, whatever, how much you may agree with them or not, to then impact what the overarching policy of the board is.
So I think like the Westlaw virus, because from that's awesome because people count on that.
Right.
Those are the kind of things we need to do. And we may have to sit down and actually talk about positions, what content, and to do that, we would need policy of what we would accept, post and what we won't accept, and that's where it's going to be very challenging. It's going to be a work in progress.
Yeah, and Madam Chair, to that point, I think that we could definitely benefit from creating some guardrails. You know, at one point, we did have another team member working with us, and she was new to our agency, and I think, you know, to be able to have to be able to hand somebody something and say, these are the parameters that we work within. Alina and I work very closely together, and we have that collaboration day to day, but I think to have that on paper, there would be great benefit to that. And just kind of every time we're posting, I think mentally we kind of do that stop and check, is this message appropriate? You know, is the messenger of that message appropriate? You know, so I appreciate the conversation today. I absolutely understand where you're coming from. We will work on coming up with a policy or procedure or guardrails, whatever you feel like is appropriate. So thank you. Ironically, my next slide is what gains interest. What we see that gains interest the most is really what you're telling us we should and can and should very freely post, and that's content that's very specific to what's happening within our public health district. Have some harmful algal bloom slides up here, just explaining to people that DEQ was testing water at Cascade and just kind of putting people on just awareness, I guess, of what was happening out there. That one received, I believe, a total of 14,000, let's see, interactions. That slide is a little bit dated, I believe, on that graphic. So anything that is really specific to our jurisdiction, what we try to do with things like this, so this one is specific to Valley County, there are several different pages and groups within our counties that we've identified. Part of the conversation today is I would like your help in identifying more so that we can specifically plug these types of messages into those groups. That's where we know things kind of spread in a good way, like wildfire. So that is where we'll ask for your help and give you some contact information for that. And the post on the other side there was a post that did really well, had people talking. Another couple of examples is the harmful algal bloom public health advisory we issued on the 13th. That one received, I think, 14,526. And then again, the Board of Health appointment process that was seen by over 5,000 people. So who's paying attention? We talked about the different channels that we're on. With Twitter, we see we have 3,900, just over 3,900 followers. Facebook, just close behind that. YouTube's a little bit unique because people don't have to be logged in and have to necessarily follow us. But 2,200 people. I think one of the Board of Health meetings, the one on December 8th, that meeting recording has had 26,000 views. And also another kind of interesting point outside of COVID is back in 2007, Central District Health created some food safety videos. And it's a series of like 4 or 5 videos that are a little bit dated at this point, but honestly, probably the most watched and requested videos throughout the country. I think I even had an international request one time for somebody, can we use these as part of our food safety training? And so that's kind of funny. It's at 250,000 views, I think is what one of the videos has received to date. So Instagram, kind of a little bit sad in comparison to the others, but that is a platform that we've just kind of joined here within the last year or so, working to build that up in time. As we look at who follows us, Facebook is really robust in terms of what information it will give you for demographics. We can see 83% are women, 15% are men. And really, in the US, the age group that uses Facebook the most, they're between 25 and 34. And then just behind that, ages 18 to 24 and 35 to 44. Just another kind of Americans 65 and older, 46% of them use Facebook. You know, I think we hear that Facebook is dying or Facebook is the social media for old people. That's not true. It's still alive and well. And it's a great platform, like I said, very helpful in what it will show you as far as who's following us. Interestingly enough, you'll see on the far side there, kind of the breakdown, and that's just kind of the initial screenshot, but that we have people outside of our jurisdiction following us more heavily than we do some of the folks within our jurisdiction. So there's opportunity there. A little bit more about demographics. Twitter, again, Twitter, YouTube, Instagram doesn't really give us as much to work with in terms of free demographic information. But we know that it's a mixture of citizens and public. We know media really likes to use Twitter. And we use that to kind of see what they're saying about us as well. Instagram, again, a mix of people. Roughly 58% of Instagram users throughout the US are female. So as I mentioned, we have some opportunities. As we discussed, we have opportunities. So adding to our conversation today is creating kind of a strategy, more of a set strategy in terms of what we post and how we post it. But we have had an opportunity to really grow our social media following, specifically on Facebook. When I looked back on March 13th of 2020, we had about 1,300 followers. And today we are up to, gosh, what was it, about 3,600. So we have really grown that audience. And of course, not all of them like what we have to say, but it's a valuable audience and that we want to retain. So we can do a better job of using the analytics that are out there to figure out who these people are, what are they most responsive to, what information do they want more of. We do try to use our in-house resources to have some of our posts and documents translated into Spanish. That's certainly something we could and should do more of and make that more of our norm. Maybe that's something we can kind of work into that strategy. And again, identifying some groups within your communities where we can plug into and post that content and really target, message to that targeted audience. And increasing engagement. What I mean by that is kind of responding to some of the questions and the comments that are coming forward and through social media. And that's a fine line. We are a team of 2, and we have a lot of other communication strategies that we oversee for the agency. So trying to kind of balance, what do you engage with and what do you just kind of like let sleeping dogs lie, right? So that's kind of an ongoing challenge with social media, and it always will be. So how can you help us? This is kind of the part of this conversation is, help us identify some of those groups within your community. Tell us who we should be following, what groups that are posting with regularity. That always helps. And that is really a part of this equation is we have a good sense of which groups are posting content on a regular basis. And those by default become kind of the go-to sources where we know DEQ is posting with regularity. We know a city has somebody kind of behind the scenes that's pushing out regular content. So that is sometimes why we might default to some of those same agencies and groups with a lot of regularity. So if you're on Facebook, if you're on any of these mediums, time to sign back up, get back on.
Well, I was gonna ask, you guys have funds to buy Facebook posts, and sometimes they're $5 to $7. Do you have a budget to do that?
No, not typically. There are certain circumstances where we have made requests to share information. If memory serves, when we had a hepatitis A outbreak, I think we did some paid social media posts. So it's pretty message specific. And I guess I did mention, I think a little bit earlier, forgive me if I didn't, is that we do get some grant money. So for instance, with COVID vaccine, we have an HO grant that is specific to vaccine acceptance outreach. And so we do have some paid social media going on for that purpose. And then we also have some programs and services within CDH outside of COVID. Imagine that do have funding streams that allow for boosted social media posts. But you're right. I mean, you can, that's the beauty of Facebook specifically, is you can say $10 to boost this post, and you can be pretty targeted and spend that money, pretty cautiously. So
if I continue, we just did that again, and we funded our social media person. I think it was 10 grand. Sure that number, so that she could buy spots like that. And I think rest might be something we want to think about down the road in the budgets. Even $500 can go a long ways to put it on the right post. So I would maybe jot that down in the budget for next time or something, because you gotta be able to get on the right sites. If you gotta pay to get on, you gotta pay, and that's just the way it is. Usually it's not very much. It's really great, because I call her up and it's like, what's the latest scrap about Valley County? She kind of tells me what's coming down the road, and so we can bring it up in the next public meeting and people can understand it. So it goes away, so it really helps us out a lot. Even though I just
Chair. Yes. The other thing is, if you're doing the paid post, you can measure it so easily. Like,
Yeah,
what's your effect?
right.
What did you get for that money? Choices pretty quickly.
Well, and it's obvious the communication with the young.
Yeah.
I mean, that's how they talk now, it's that way. So we need to get on top of that and stay with it, because it's gonna be the future. Even though we're fine.
If we were gonna spend money on it, though, we need to make sure that they're smart policy.
Right. Yeah, there's some work that needs to come in front of that, but I think it'd be worth the investment.
And then just to wrap it up, if you do have ideas, please reach out to us. That is the email address that reaches Lena and myself, the administrative assistant that works to support a number of us. Here's where you can find us: Facebook, Twitter, Instagram. One thing I didn't mention, I failed to mention earlier on, is we did create an Elmore specific Facebook page that is somewhat geared for COVID. And that is an opportunity, is creating more of that custom content speaking to that audience. The challenge, of course, with creating specific pages and more Facebook platforms or social media platforms is maintaining it. You have to be consistent. You have to, post on a regular basis for people to listen and also to share your content. So that becomes a major consideration when people come to us and say, well, can we get a page for this or a group for that? We have to be cautious and really kind of leaning forward on who's going to maintain it beyond maybe the first year, because it's exciting at first, right? And then the newness wears off. So yeah, so that concludes my presentation. I'll see you for questions.
Just had a comment. Thank you, John. You get more comments positively, people about the information that they gather from what you posted. Thank you.
Well, Christine, if you have to stay there, Russ has something to say.
Yeah, of course. Right. So I did share with the board via email, hopefully you got it, that Christine is leaving CDH in early September. And I just looked back, this was a position that came about around the 2001 era, 9/11, and then the anthrax attacks that took place after that. And
I wasn't around then, I didn't join until 2005, but I think about where we were prior to her joining, I think 2013, and where we are today. She has single-handedly redefined the role of a public information officer for this agency. I'm just so impressed. She's been an influential member of our management team, tremendous resource to the community, completely stepped up our game. You know, when you think about all the things she covered, this is just a small piece of her job and our team now with Kalina to communicate with the public and do it in such a professional way. Think about the internet, the website content is amazing. And she's, I will say, an absolute master when it comes to communicating with the media. And either she's doing it or she's preparing others. And as you can recall, lots of last minute requests, and Russell, you talk to them, and you know, next thing I know, I get all these talking points, like, and it's like, wow, that was 10 minutes ago. And it's just like, to me, just over the top. And the last comment I'll just say, just this last year and a half, it's been tough on everybody, tough on the community, tough on this agency and our staff. And without exception, I could count on Christine day, night, weekend, when she was supposed to be on vacation, like just get stuff done. Like nobody's business is what I'll say, because that's the way it worked. And I know our team here, across the board, I don't know anybody that hasn't worked with you in some capacity, whether it be a flyer they were developing for the program or having to prepare for an interview. You've just done a tremendous job. Certainly wish you were not leaving, but you didn't ask for my opinion, and I get that. Respect your decision, but you're going to be missed, and I mean that most sincerely.
Thank you. I really appreciate the words, Russ. Thank you. It was everyone says it right. It was a very tough decision. I've been here for almost 8 years and feel like public health took a chance on me. I came from transportation world, did public involvement, public relations there, and just really love the people that I work with. This team is just incredible. It will be jumping onto a new challenge, but I'm excited for it. And I'm just so grateful for your leadership and this team. It's just, I love being a part of it. So thank you to all of you as Board of Health members. The job you've had is incredible. And thank you for your persistence and resilience. So thank you.
Thank you. Okay, Laura, we would like to hear about your new ag school grant.
Laura's right there.
Oh, okay, fine, Laura.
Hi, everybody. Thank you so much for letting me join virtually today. So I am here to share a little bit about our newest Farm to School grant. I hope you can see my slides now. So as a little bit of context, the Farm to School grant is a part of the National School Lunch Program, and the National School Lunch Program actually began in 1946 as a USDA program to improve on-child health. So following the war, they noticed a number of soldiers weren't ready for the job, so to speak, because of diet and health-related problems. So the National School Lunch Program was brought on to improve child health and also to create a market for our national agriculture. So the National School Lunch Program has many facets, but the Farm to School grant is one of them. The National School Lunch Program serves 30 million children annually and spends about $1.26 billion on local food. So I just want to kind of set the stage for that, as Glenns Ferry is joining a really important community, and it's a really phenomenal opportunity that we're able to provide down there. So the grant we applied for in January, and we were awarded in July. As I said, it's funded by the USDA Food and Nutrition Service. We will be the administrators of it. Our role is largely technical assistance and training, management of the funds just to support the school district. But the majority of the funds are going to Glens Ferry, so it will be paying for their staff time, supplies to implement the program. So Glens Ferry is an absolutely essential part of this. We have a great working relationship with them. We've been working hand in hand since the initial idea for the application began. So this will be a one-year grant program, $62,000. And we have already gotten started, which is kind of fun. So again, just to set the scene a little bit, these are some national stats. Elmore County has an obesity rate of 35% and a food insecurity rate of 13%. On a self-report, 13% reported limited access to healthy foods. We have already been tackling some of these persistent health challenges in Elmore County. Everybody has probably heard about our Get Healthy Idaho grant program that's running right now through the Western Idaho Community Health Collaborative. And then, of course, our Elmore County Health Coalition has been a mainstay for a number of years. We have partners from all facets of the community in the Elmore County Health Coalition, from elected officials to healthcare to social service providers, faith community, schools, library, and just individual citizens as well. A whole lot of people caring about health down in Elmore County. So we're leveraging those partners to really make this a robust program. Also worth mentioning, since we're talking about farming partly here, is that Elmore County contributes 6% of Idaho's agricultural sales. That totals about $43 million. So we're really working in a community that already has an investment in agriculture, and to keep that local to provide the economic benefit through this program as well is going to be just really amazing to see over the next few years. The Glens Ferry School District operates on one campus. They have grades K through 12 and about 400 students. Within their school population, about 3/4 of those students are eligible for free or reduced price lunch. So that goes up to 185% of the federal poverty level. And 25% of the Glens Ferry residents live at or below that federal poverty level. So the need for school food and healthy school food is certainly there. With 3/4 of the students being eligible for free or reduced price lunch, we can estimate the number of students that are eating free and reduced price lunch or purchasing lunch on their own. So it's definitely incumbent upon the community to bolster that food to make sure that we have healthy offerings for those students. As I said, we've already gotten started with Glens Ferry. They are absolutely ready. So even prior to the application being submitted and this whole program being thought through, they had started in on a greenhouse. So this greenhouse will serve as an educational opportunity for the school district, I should say, at all levels of school. The established agricultural education and FFA opportunities are within the high school. So that's really where this is beginning. But they are already integrating nutrition into science classes at the middle school level as well. They're participating in the fresh fruit and vegetable program, which is another USDA program aimed at the elementary students to, as you would think, engage in eating fresh fruit and vegetables. It's really an exposure opportunity for them. It's an opportunity for them to learn about fresh fruits and vegetables as an alternative healthy snack. The school food services department is greatly interested in this. We had a phenomenal meeting with Superintendent Cody Fisher. He brought in his school food services director. She is really engaged in healthy food. She is really interested in looking more towards scratch cooking, which is absolutely a best practice when feasible in schools. So there's a lot to build on there, and the enthusiasm is really wonderful to see. We have teachers who are going to be engaged at all levels. Superintendent Fisher has identified teachers at the elementary, middle, and high school levels. And then he himself is really invested in this program. He was brainstorming any number of parents who might be interested in being involved. So this is really a community program as much as it's school-based. It has reaches to every single corner of Glens Ferry, and of course, calling on the agricultural community to be a key partner in it as well. So what is the plan? The plan is kind of, I say threefold, but I have 5 bullet points here, so we'll go with 5. So garden education, of course, is the key to this whole thing. Installing that greenhouse, ensuring that it gets utilized in an academic setting. providing that agricultural education in the classroom. So tying it to curriculum, tying it to lesson plans, making sure that we're not being redundant. Teachers already have so much to be doing, and there's so many opportunities to pull farm to school into the classroom to accomplish those lessons. There's also so many opportunities in the cafeteria. As we all know, kids don't stop learning once they leave the classroom. Observing what's happening in the cafeteria, having those modeling sessions, those role models, all of that is going to be really impactful. Local procurement is something that will not necessarily be accomplished this year, but we are certainly going to work for it. We are going to build the foundation for it. And then program sustainability. We have a one-year grant program, but certainly this is something that the school can do with or without a grant program in the coming years. Also other funding opportunities that they might want to capitalize on. And then to wrap it all together, we are going to try and revitalize the Idaho Farm to School Network. So I'll talk a little bit about that towards the end. So for the garden education piece.
Good question.
Yes.
Laura, Megan has a question for you.
So as a grower, I have questions because I see agriculture community and I'm interested in understanding how you see that as working. And then I'm also interested in what you actually think you're going to quote unquote procure locally. So those are the two things that I'm not following.
Sure, absolutely. So local procurement, there's a number of different roles that growers such as yourself might play. Way far down the line, there are many school districts that are purchasing their foods locally. So that is something that we can do at a very basic level this year in Glenns Ferry. So purchasing apples locally is pretty simple, all things considered. There's not any cooking to be done with the apple. It's just something that you are already purchasing and providing to the students in the cafeteria. And so instead of that invoice coming from a food distribution center, it can come from a local grower. And so there's all sorts of tools and trainings that we can help the school district identify and participate in to engage in that. Then on the agriculture side, on the grower side, it's helping growers, as you just suggested, understand what that might mean. So it's a heck of a lot of work to be selling to this place, that place, another place, but streamlining, helping them understand what happens within the school system and how they can fit in is really key. Again, farther down the line, working towards a scratch cooking operation is something that Glenns Ferry has identified interest in. So that might be purchasing local onions. A lot of onions are grown in Idaho and nearby areas. And so maybe it's purchasing those locally instead of from a national distributor.
I have concerns about how functionally it's going to work, but.
Laura, this is Diane. I also, as Megan, come from ag in Elmore County. And does this fundamentally start this program with education on soil health, since the whole thing revolves around soil health?
It absolutely can. One of the wonderful benefits of Farm to School program is you can take it where you want it to. So soil health is something that's absolutely pertinent to engaging in greenhouse and garden studies. And I hear you when you say you're concerned about all the processes involved with procuring locally. This is not something that Central District Health is making up. There are many, many resources from the USDA programs to help support schools and growers in doing this. So we'll be calling on those examples to really implement a program that works locally.
Right. Have you involved our local county agent to help with this?
Yes, we are involved with the Extension Office. We are also working with the University of Idaho Farm to School program. So they are the ones who have been working in Farm to School for a number of years. Working with the local Department of Agriculture will certainly be key to this as well.
So it's Brad, that's our extension agent. Has he actually given you local places of procurement? Because I guess we're a commercial grower, okay? And most people in the area are commercial growers. And while everybody has this romanticized idea of farm to table, I'm functionally knowing what growers in my area do. I'm trying to figure out how this is going to functionally work. I'm not arguing that there are established plans for everything. I'm not arguing that the USDA has great ideas. I mean, they reintroduced wolves, the federal government did. And they always have great ideas. I am concerned about, I mean, I'm willing to help where available, but I'm just really actually pretty deeply concerned about how this ties in with local agriculture. I can see how, you know, greenhouse, soil health, discussing irrigation options, but when you start talking local procurement and working with local, I can only think of one, it's Nate, one vendor.
I was thinking of Nate.
Yeah, I can only think of one person who does smaller scale and varietal crops in the area. So that's what I'm just thinking on the ground of how this functionally works. So I didn't know if Brad's already got you set up with multiple folks that are willing to work with you, then I guess he's got it handled.
And we have not, full disclosure, we have not fully gone into the local procurement part. As I said, we're just going to be working on foundation building with that this year. So no, we are not currently in conversations with any farmers, local growers, things like that. We're just getting started, excuse me, on this. But I worked in farm to school for 4 years before coming to CDH. And so I absolutely understand the concerns about working with commercial growers and everything. And I would be more than happy to sit down with you guys and kind of go through my experiences working with farmers and kind of the conversations that I expect we'll be having down in Glenns Ferry.
That's great, Laurel. Laura, I would like to refer the name of the fellow that Megan just previously mentioned. He is really fundamental in soil health as how it is foundational to public health. And so I think he'd be a great resource.
And that was Brad, and I did not catch his last name.
Brad Stokes is
He's our extension agent.
Nate Jones actually has a retail produce business.
Yeah, Nate does multiple crops.
Yeah.
But like I say, most of us are commercial out there. You can't survive real well, but Nate's an organic grower out there.
Great, thank you. Shall I keep moving?
Please.
Okay, thank you so much for the questions. And again, I am more than happy to chat with you guys offline, bring in a conversation with Superintendent Fisher, whatever is most pertinent.
I'll talk to him when I get home. He lives across the street from me.
All right, perfect. So within the garden education, we are already in the process of developing a planning committee. The majority of those folks will be school-based because again, this is about empowering them to sustain these opportunities long after the grant program is gone. So we'll establish a vision, goals, objectives, and so forth, what they want to accomplish with that garden year after year. Of course, complying with applicable federal, state, and local standards. Developing a curriculum plan will be really essential. As I said earlier, we don't want to just throw another thing at teachers for them to accomplish. They have a lot on their plates, and so it's going to be making sure that they're adopting a curriculum that meets Idaho school standards. Developing a food safety plan so that any foods that are grown, we know are safe and are followed a specific process. Processing, storage, and use of those garden foods. So following that safety plan, maybe it's using those garden products in a classroom for study within science or nutrition. Also taking into account opportunities to bring those foods into the cafeteria for maybe a tasting event for students. So we'll get all of that hammered out. And then procuring and installing the supplies for the garden and greenhouse has already begun. And then we'll, of course, propose a training day and work with teachers for curriculum training so that they understand how those connections can be made. For the agricultural in the classroom, a lot of it's very much the same. It's determining those desired outcomes and competencies to be achieved through those curriculums, through the lesson plans, identifying who will participate, whether it's high school specifically this year and working our way down, what it's looking like it's going to be as an opportunity at every grade level. And then, of course, connecting with the Idaho Department of Education, just really making sure that we have this toolkit that they are able to use and that potentially other schools are able to use in the future. And then in the cafeteria, there's all sorts of opportunities for integrating food education into the cafeteria. Kids are going there to eat. They're learning about what they eat, whether they realize it or not. One of the fun programs that I used to help with was called a Make a Rainbow at the Salad Bar Day. So that's exactly what it sounds like. It's teaching kids about different colors of fruits and vegetables, why that's important, what they like, what is available to them, what they might like to try again. Local food tasting day. So that could be working with local producers to bring in, as I gave an example earlier, a local apple, talking about how important it is to know your farmer, know your food, work with those local growers when possible. Garden food tasting day, as I talked about earlier, and then just ensuring that there's some synergies between what's happening in the classroom and what's happening in the cafeteria. Local procurement, we talked about this a little bit, but drafting a procurement plan will really be the name of the game this year. We're not expecting a full implementation of anything local procurement. It's just kind of laying the groundwork. So how will they be incorporated? What does that mean on the farmer side? What does that mean on the school side? There's so many intricate processes that happen there. So delivery, processing, storage is pretty far down the line. It's the ordering, it's the growing, it's the quantities. There's so many pieces to it, the safety. And then also calling on project partners to promote the farm to school program so that, again, we can really make this sustainable long term. So within that sustainability, identifying program support. So we really need to identify those farm to school champions within the school building, within the agricultural community. That may be Brad Stokes, that may be Nate Jones, that may be Megan Blankspun, Betty Ann Nettleton. But just engaging with those people who really know the community, who are invested in this program, and help it expand. The Master Gardener program, other food producers and vendors, and so forth. So there's integration connections through existing events. So that might be a farmer's market, that might be the fair. And then of course, looking at future funding opportunities. The Farm to School grant is just one of many funding opportunities out there. And so ensuring that this program is able to grow in the coming years. And then finally, the Idaho Farm to School Network. It exists very much in name only at this point. We've been in touch with the University of Idaho Extension Office. So they have a farm to school director and program assistant, but they are mostly focused on farm to early childhood education at this point. And so the farm to school program kind of doesn't exist at a state or regional level anymore. The Idaho Department of Education used to maintain this program. With staff turnover, then that support left. So we really just want to re-engage folks, have a network of folks to chat about it. From conversation begets action. And so really just growing those opportunities, those coordinations across all aspects of local agriculture. Idaho Preferred is a program to call on, certainly. That's engaging with the local farming community and leveraging those processes that have already been brought forth to support local agriculture. It provides opportunities for sharing between school districts. As I mentioned, we hope to come out of this program with some semblance of a toolkit so that should another school district want to implement this, then they aren't starting from scratch. And so with that, I'll take any further questions.
Yes, go ahead.
Laura, I think this is great. You know, what we're finding out now in a lot of these schools is that kids need to be exposed to different professions. And one of the big ones, of course, is trying to grow your own food. In Valley County, we rely heavily on the Master Gardener program. And I think over the last 4 years, 5 years, we probably certified, I don't know, I guess a number between 50 and 70 people. And part of that program is once you become a Master Gardener, you have to go and teach that technique to other people up to 2 years. You don't get paid, it's just part of that certificate. So I would definitely look at that program, the Master Gardener program, to help you with this. One of the things that we found out is not only does it pull in the parents, but it pulls in the kids as well. And the next time you're up through Cascade there by our food bank, there's a little Master Gardener beds out in front along the highway. And it's very popular. A lot of people really like it. And so we've kind of expanded that, helped the U of I expand that and just expose these kids to how do you plant a seed, how do you water it, how do you make it grow. And some kids love it, some don't.
But they all like to eat.
They all like to eat. Yeah, and it's like, where do we plant the chicken nuggets? Well, that's a whole different process.
Yes, thank you for that.
Yeah, great work. I think this is awesome.
Well, thank you, Laura. This is Betty Ann again, and I'd be happy to, if you need any classroom lectures or anything, high quality protein, soil health, that type of thing. We have 2 people within our family that would be very good at that.
Wonderful. I will certainly take you up on that.
Great.
Good. And I would just say Brad is really involved when it comes to as far as the FFA program, and he's very involved in 4-H. And I'm concerned about this. I understand everybody thinks it's a good idea, but what I'm hearing is there's no plan, and knowing what the reality on the ground is, I'm worried that money will get spent inefficiently. And so I have concerns, I guess, of how this is gonna work. Just knowing what the conditions on the ground are.
Right.
And not that I don't want it to succeed, but I don't even, I'm unclear as to what success is. I don't know that I understand what success means with the presentation. I think that Elle has got a great point. The Master Gardener program makes a lot of sense to teach these kids, and a focus there I think would be fantastic. And I know that Brad is deeply involved with the Master Gardener program and would love to help promote it. And that seems like it could definitely be a success. But again, part of it is my own personal bias. This whole local food thing is a very Boise North End deal. And this farm to market type idea, and on the ground in our area, it is much more commercial. And so I think it's important, but some of the stuff could be learned through the Master Gardener program, when you learn irrigation techniques and soil health and that kind of stuff.
Well, and I think it represents a big opportunity too, because, well, in our case, we do a lot of the intensive management on grazing as far as the soil health and then high quality protein. And we do market some of that locally. Yeah. Yeah.
Yeah, I was just gonna make a quick comment before we go on to the next agenda item, just how much I appreciated Laura's investment of time in getting money for our communities. And as you all know, she's a presenter at other board meetings. She totally embraced the district concept. The largest grant we've ever received is for Valley County. This is just an example of the work that she's done. Part of the reason we included the grant writer in our budget wasn't to replace her, but to help support the whole agency, all the direct services. But this is one of the big focus areas, is the health promotion, health policy area. So she's just doing a fantastic job, and she knows she has really has a whole lot of experience working with schools and working with USDA grants. And I get it that none of this stuff is like prescribed exactly. I mean, that's why we work with all the community partners, and just pay yourself or make the connections if there's more beyond what she's already done. Thanks, Laura.
Thank you very
Thank you,
much.
Russ. Thank you all.
Okay, proceeding on with our agenda, we need a discussion about a new trustee.
Well,
It's timed out.
I'm gone, and Dr. Everly was appointed, of course, he's gone too, but I guess I've been thinking a lot about this lately, and I'm not sure if the executive council is gonna continue, because if we're counties are doing our own budgets, we don't have to follow state formula anymore. I'm not sure what the need is for an executive council, other than maybe the annual conference.
Sure.
Yes, Russ, go ahead.
So this role is the trustee. And you have the executive council, the trustees to set the formula, the board of trustees sets the formula for the state general fund appropriation, and the executive council is the group that meets around policy work, whether it be COVID related, where you're talking with the other public health districts, or more often it's related to the legislative session, as you know, because it's pretty, well, you were in that role, Madam Chair. So the executive council, in my opinion, will continue. The board of trustees' responsibility is now very narrow. It's the Millennium Fund dollars. And if the legislature, if they had the interest in just designating that money out to the public health districts, like they've done with the citizen review panel money, like district, District 1, this is the amount you get, rather than having a formula, you know how the debates go. Then that would eliminate the need for the board of trustees, but there still is a need for a trustee because you still have the Millennium Fund dollars, you have the home visiting funds, which was designated by the legislature, but the trustees can change that, and that's going to come before you next spring for next.
We've never talked about that.
Wait a minute.
Right.
Whoa, what did that allocation look like? They didn't allocate by, I thought they allocated it. What do you mean changing the allocation?
So it's allocated by health district
Uh-huh.
in the appropriation. Everyone agreed.
Uh-huh.
That's a problem. It was a problem from the start.
Right.
So where we're at right now is one of the last executive council meetings, there was a discussion because there's the authority of the board of trustees to reallocate that money if there's complete agreement among the board of trustees.
So you're talking about the fund that everybody just got $7
$1 million
and it
for,
was split 7 ways, right?
no.
I don't remember.
So there's citizen review panel money, everybody gets $19,500. There's Millennium Fund dollars, which is an appropriation to the health districts for tobacco prevention and cessation. That is decided by the board of trustees. And then there's the home visitation money that is prescribed in the appropriation bill, but in the bill language, it says that this is how it goes unless the board of trustees decides they want to use a different distribution mechanism. Representative Blanksman knows right out of the get-go, it was I'll just say it, a very flawed formula. We get almost the least amount of money in the state with 30% of the state's population. So we've been discussing how to correct this. Now, it's either going to be corrected by the legislature, which would be great. My point earlier, if that's taken off the table,
Do you remember what bill it was?
I can't.
I just, Madam Chair, the only reason that I bring that up is, and obviously Raul served in not just the legislature, but Congress, but I did not realize there was language in that bill text that would allow for redistribution.
Yep.
And I don't know, I guess I could talk to Raul later. I just.
Sorry, it's Amber.
It's Amber Alert.
Yeah, I'm sorry, I didn't bring it. I didn't really talk about that, but it did.
Okay, so if I can, House Bill 396, right? Citizen review panels. The amount appropriated in section 1 of this act, $136,500, shall be distributed to each public health district. Monies received by the health district shall not be considered general state aid for the purpose of this section, nor shall monies be allocated through a board of trustees formula.
That's CRP,
Huh?
that's Citizen Review Panel.
Yeah.
That's not what I'm talking about.
Okay, so
Home
you're talking
visitation-
about
home visiting money.
home visiting, so
And a lot of that was based on, trying to remember, it seemed like District 1 got most of that money because that was a big part of their program.
right.
Some districts weren't doing reproductive health, they gave that whole thing up and went totally into home visitation stuff.
Well, and part of it was, how much are you spending today? Well, with the federal money that was coming into the state, 2 health districts were already getting a larger share of that appropriation, and the legislature just decided to use whatever they were getting today as the means to divide up what it started out as, I think, $1.8 million, which again,
So you're getting a lot of extra money from the federal government based on something that's outside of any local control. That's a federal money coming to the state that comes to us as a contract to all 7 public health districts. So then you got even more money. So there's about 3 districts, including District 4, my opinion, it's a real problem because we clearly have the need, and we need to get it corrected. So the appropriation bill should say that here it is, District 1, you get this much, District 2, you get this much, and then there's some extra language in there that says Board of Trustees or somebody, health districts decides how to redistribute this, they can, they just have to have, I think, unanimous agreement to do that. Thank you.
Which bill is it?
So I think it's, let me scroll, it's 1173.
So it's a Senate bill.
Yeah. So for home visitation, Idaho code, nor shall the monies be allocated through a Board of Trustees formula, allocation of these funds. Further, public health districts may reallocate these monies between the districts, but only upon unanimous occurrence of the Board of Directors for the public health districts, which Board of Directors is who, doesn't exist. So I would say, being that it's always been the trustee's decision, unless there's some AG's opinion that's just otherwise, it seems like that would be who would decide that this money would be redistributed differently. It's section 9.
Well, I think the first issue, Russ, is we gotta find another trustee because I timed out.
Yeah.
That's, you know, that's kind of what happened with Doug Center. Doug's timed out and Rick Johnson is that trustee now.
Well, I suppose in practical application of no more than 3 consecutive 2-year terms, not consecutive, you've been out for almost 2 months.
I see where this is going.
I just want to make sure the board's aware.
Well, and honestly, I think if someone else wants to do the job, they should have that chance. It's pretty much been all online, of course, through the COVID deal. But I think it was District 5 that was running the show this year. So a lot of the stuff came through them. I think the commissioner that ran most of those meetings, but if someone else is interested, I don't, either way.
Jane, I think it'd be wonderful if you wanted to do it.
This is Raul, Madam Chair.
Yes, Raul.
Yeah, I don't have a recommendation and I have no problem with ELT continuing. My only concern is that I disagree with Russ's interpretation of consecutive. I just in order to not be challenged, I'm not sure. I mean, I would love to have ELT back on there, so has nothing to do with him, but I think that's a little bit too cute by half to claim that because we didn't appoint the person who was appointed was not eligible, and I don't know that we can make the argument that it's not a consecutive term, but I'm open to a legal opinion.
Is the lawyer in the room, right?
I just don't want, I want to make sure we do everything appropriately.
Right. Thank you, Al. Yes, Russ.
It's actually in the bylaws, it's not a law. So this board actually, if there was some debate about whether that 2-month vacancy, Ted was appointed at a time he was eligible because he was a board member. He was elected by this group, and he never had an opportunity to serve because his term expired and he was not reappointed. So that and the board has changed the bylaws, as you may recall, in the past a couple of different times. So if there was some debate on it, and you guys wanted ELT to serve, you could just change the bylaws and say no more than 4 consecutive 2-year terms. And that would get you out in 2 years.
Well, I have 3 more years as commissioner, and then I'm
Madam Chair.
Yes.
Question. So the consideration, A, and I don't have the bylaws in front of me, is is the appointment required or can it be left vacant for the time being? And B, is the only consideration why you would need a trustee would be the Millennium Fund distribution formula. Because when I look at this section 9, it says board of directors, that is not the board of trustees and could even be construed to be you. Because the directors all meet together. And so I think there's a whole lot of vagueness in that language. Also, probably the realities of reallocating those funds is not realistic. So I'm just wondering if this is something that can be put on hold until October, if we're interested in reviewing the bylaws and if, I guess would be my point, because nobody is really jumping forward for this job, I'm noticing.
Well, that's
And I definitely was not jumping forward for the job.
If you just log off for a minute, we can solve the problem really quickly.
All I can say is I'd be willing to do the job again. I don't have an issue with that. In fact, one of the goals that we're gonna start working on as an executive council this winter were food fees. Because that is in legislation, what we can charge for food inspections. We felt like, okay, if the counties are taking all the funding on, then we want the authority over food fees. So that was the next battle that we have been kind of tossing
Sure.
Yes, Russ.
So there's two different roles. There's the board of trustees, which is an Idaho code, which has one job, which is to determine the allocation formula for general state aid and any other state aid, which there is a decision point to be made. So for the Millennium Fund dollars, the board of trustees makes that determination. So the appropriation for this year, it's been set. For next year, the board of trustees, I guess to State Representative Blanksman's point, that would not need to take place till a later date. Although I will say, the longer it's delayed, the less likely there is to have any adjustments made because, well, we need time to write this, that, and the other thing. That's how it goes. Versus trying to have that conversation this fall, and that's what I would prefer, especially around the home visiting funding, which board of directors, who is that? I guess nobody knows. Certainly, it's never been given to the public health district directors, which is an association by a volunteer association that I sit on. So that's one function, right? You got the board of trustees, and then by default, not by law, not by bylaws, that position is also served as the executive council member, and they've done this statewide. But again, you could have two separate people, one serve as a trustee, one serve as an executive council on the same board, and that's your call. The executive council is not, and it's not been formalized. It's something that the districts have agreed to do to get together to talk. I am concerned about the home visiting formula, and I think a decision needs to be made this fall. Once again, if it doesn't get made this fall and it gets kicked off, put off till next spring, it'll be another year. And it'll be really advantageous to this agency if we can get that corrected as soon as we can. Does that make sense?
So maybe what we could do, Russ, is in the meantime, get us a copy of the bylaws, what it would take. Well, in the bylaws is how you extend a term and how you do this or that. Come back in our next meeting and do that.
I put this suggestion out there too, because I know you guys have some discussions coming up in September, usually associated with the IAC Midwinter Conference, which is ahead of our October 15th meeting. I don't think there's anything that you can designate out as the acting trustee / executive council member until the bylaws are reviewed and a decision is made.
What, Madam Chair, so what if you just designated an acting executive council member and steer clear of the trustee, which sits in code, versus the executive council, which is a made up group?
And really, I think all the executive ever did was lead the business meeting, the annual convention. Excuse me. And then that was it, we were done. If I remember right, the trustees, all they did was the formula and that's gone, so
But it's not.
Well, it's not, but, other than the Millennium Fund, that's about all we got to do. But you're saying the,
But you can't.
home visitation is another one that we need to look at.
Two, there's something, fund dollars, there's question about home visitation because it says board of directors versus board of trustees. What does that mean? I will tell you that the board of trustees is going to be making a decision on the home visitation formula possibly as early as September. So that's the sense of urgency, if I wasn't clear.
Madam Chair, I would also say though, there's the 2-year hold. And so that creates an issue. When did they last time set the formula for the Millennium Fund? Was it last year?
It's been years.
Has it been years?
Yes.
What fund was it that we did 1/7?
That's the,
CRP Citizen Review Panel.
yeah. That's messed up too.
I don't know, you guys might want somebody that's got a newer, fresher mind because mine's starting to get really
It takes a lot to get the culture and to know what you're doing. And
Well, Ryan's not on the phone anymore.
Yeah, what Jane just said is very true. You're into the culture and you are familiar with what's on the responsibilities. So if we can make it happen to have you at interim.
That's fine, I can do it.
Yeah, I think good promotion, so it's documented. And then,
Do I get a card?
yeah,
Of course. What kind?
say a card. You get a card with your name on it, it says trustee. I thought you said card. Christine's working on it right now, it's not about.
Okay, so we have a motion to make Elves an interim trust. No, should we call it trustee?
But it.
Well, by definition, if you're on the executive council, you're a trustee.
No, chair, no.
Yeah, we talked, where did we?
Vice versa, so.
Vice versa?
Yeah.
Okay.
Yeah, as a trustee, you're on the executive.
Right.
So if you know Russ, like, Glenn Bailey, he's been on there about as long as I have. Has he been timed out or did they reappoint him, you know?
No idea.
They might have different files.
Oh, probably. I think who else has been, you know? Bill Lake.
He's still.
He's been there at least 7 years.
Sure, I know this isn't on the agenda, but I think there's a bigger question we've got going on here of what makes you think that they're gonna change the allocation?
Of the home visiting
Yeah.
visitation, because all the directors agreed to it, and generally that's like a really good starting point, so you don't have a director saying, I'm out. So the district directors have talked about it, and we have all agreed that it's appropriate to change it. We've agreed on formula ideas that we present to the board of trustees, and there's been a discussion about having that conversation as early as whatever meeting is in September. Which, by the way, is also a little bit of sense of urgency because we are, as the host of the Idaho Association of Local Boards of Health annual meeting, it's our trustee and our executive council member who leads all those conversations, including the one coming up in September.
Put a little more pressure on me, man. Trying to figure out when IEC is, it seemed like it was.
So it seems like, this is Raul, Madam Chair.
Go ahead.
It seems like the solution is, I agree with Megan that there's some complications if we have something that's set in statute, which is a trustee. And it seems like it can be easily solved by having the other interim appointment. Am I mishearing that? Or, so I don't think we should play around with just changing the way we do the trustee issue since it's set in statute, and we can come back at the next meeting, and if we decide that ELT is the one to do it, we can change the the bylaws at that time.
Well, do you have your computer up?
I do.
Can you go to the session, this last year's session, and when you look at House Bill or Senate Bill 1173 and it's on page 4, line 35. There,
I'm there. Line 35.
35, so it says of the board of directors, but state statute, section 39-411, never says a board of directors, it's always referencing board of trustees.
Oh,
Do you see what I'm looking at?
yeah.
And so I don't know that even if we had a trustee, I don't know that's why I'm asking the lawyer in the room, right? I don't know that would apply because I mean, I guess maybe the intent language was to put board of trustees, but that's not what they put. And so looking for an opinion.
Well, I'm not going to give you a legal opinion, having just looked at this, but is there a board of directors for the public health districts?
No, there's just an association of the directors. So they've conflated two things in the language of the bill of there's the board of trustees, but then there's the association of directors.
Yeah.
Am I making any sense what I'm saying here? Yes.
You are, no, and
Raul, this is Betty Ann, and in our bylaws, section 14 states that no person shall serve more than 3 consecutive 2-year terms. Now, can we still maybe just call this position an interim until we maybe change the bylaws?
I think personally, it's a run around the intent of the bylaw, and I think that would be inappropriate. Now, people do it all the time, but I do think by just calling it interim, you're just getting around the bylaw, and not having been on the board for a long time, I don't want to start a process where we're just using the bylaws as guidance instead of strictures. So.
Well, and what I see is a twofold. I agree with Raul, and our second problem is the language in the code, which if challenged, you have a problem, right? So assuming, which I've never really seen, all of the trustees get together and high five each other on one thing and it's unanimous, as long as it doesn't get challenged, then it's fine. But if it does get challenged, you have ambiguity.
Yeah, if it's a 3-2 decision, and ELT is on the majority, it could be challenged.
Well, and it says it has to be unanimous concurrence. But okay, so there's another question, I guess. So is unanimous concurrence of the whatever we're gonna call it, does that mean that does unanimous mean that it has to be, all of the trustees have to be there, or is it unanimous of trustees present or this director's present?
I don't think the directors have anything to do with it. It would be unanimous of the trustees. When we redid the formula here, 3 or 4 years ago, it was like 5-2, I think. So it was approved unanimously by the board. Unanimous doesn't mean 100%. I guess it should have said majority.
So Russ, can you educate me on this? Was this bill or Megan, was this bill a complete change to the law for this year, or
This is the home visitation program or the trustee stuff?
the Senate Bill 1173?
Yeah, that was just for this year. We've had some problems dealing with the allocation of the home visitation, and admittedly,
I knew the allocation was screwy because Russ and I had talked about it, but I didn't know that they threw this little gem in here. I didn't see that one when it came through. The
Okay.
concurrence of a board of directors that doesn't exist. So that's on me. I didn't see that one.
Yeah.
We meeting in September.
No, October.
So it would be way after IAC before we can decision.
When is the meeting?
Council is gonna get together at IAC, they've already said.
Raul, did you have something to say?
When is the meeting that we're concerned about in September?
September 27th through the 29th is Idaho Association of Counties Fall Conference, and it's where we start a lot of the legislative stuff. All the different committees meet, do resolutions, and we almost always, as an executive council or board of trustees, met one night at that conference for dinner, and we talked about issues and things that we were thinking about.
Why don't I just a suggestion, maybe we can think about this and have a short meeting in September, sometime the second week or something like that, to discuss this issue. And maybe we can discuss the other issue that we talked about earlier.
That, and to Raul's point, that gives me enough time to call the AG and ask for an opinion on this board of directors language to find out if it's even doable.
That would probably be best conducted just virtually. We have that limited agenda.
Yeah.
We could, that would be great for me because I'm in Hawaii 15th through the 23rd.
Yeah, I moved that we all go with Elle to Hawaii.
Excellent, second.
I'm ready to go tomorrow.
Okay, did I, all the noise going on, did I hear a motion? Or was that just a joke?
It's just,
It was a joke, I apologize.
Okay, is that a motion?
I can make that a
we
motion.
can do subject to the call.
State and chair can.
I'll
Okay,
follow the chair.
all right,
I'll follow
okay.
the chair.
Yeah, because if we find out from the AG that this is messed up anyway, then there's.
Okay, so I go second. Take a vote by county, Raul,
Yes.
Dr. Young,
And Young, aye.
Elmore County, Megan.
Yes.
Boise County, are you there, Ryan? Valley County? No.
Commissioner Esper.
Okay, all right, motion passes, so. Figure out virtual meeting.
And I think, let's look in the meantime too with the bylaws. What if we take a change on it? We can probably do that. If we have to. Do an extension or whatever you have. 4 years or 4 terms or whatever you want to call it.
Madam Chair.
Yes.
So is that wishes of the board, we'll change the bylaws to say no more than
I think
4 consecutive 2-year terms. You can vote on it at the start of the meeting and you can appoint you as the trustee if that's what the board wants.
I think that it has to be decided at our virtual meeting.
I would assume so, so I would have that authority when I go to IAC.
Right.
2 weeks after that.
Okay.
I'll bring the updated bylaws, that'll be the first agenda item, and then you can elect a trustee
Okay.
who also serve as the executive council member.
He gets a new card.
That's right. You can't hear it on the.
No.
Okay, all right. I guess that item is taken care of then for the time being. Russ, you want to talk about our annual meeting?
So Central District Health is the host, Public Health District in 2022 for the Idaho Association of Local Boards of Health. This year it took place virtually. It was only the business meeting, and it was hosted by Twin Falls. So being that next year we're the host, the decision that this board needs to make sooner rather than later, and I say sooner rather than later because if you're going to do something in person, trying to secure hotel rooms and conference rooms and all that, we're already heading into the pinch point. So you really have the decisions are one to do the traditional meeting, which was about a day and a half. Or do you want to just do the business meeting, which is about 2 hours, 2 to 3 hours, set the budgets, talk about policy, resolutions, things like that. And then you want to plan to do that in person or virtual. And then we need to pick date preferences, give me some ideas, so we can begin working on it. So probably the first decision point is, do you want to do the full-blown meeting, or do you want to scale it back to what we've done the last 2 years, which is the business meeting only?
Can we provide like reasonable content if we did a full-blown meeting? Like actual things other, and as much as I like fun trips as the next guy, do you think there's like content that we can provide, or as far as a class, as far as something that would prove worthwhile? Rather than just, hey, come to Ada County or Valley County and have, dinner with all of us, with people that you normally would never hang out with.
Yeah.
Madam Chair, just for your information, because we did it virtual this year, there's quite a bit of money left in that budget. I think it's for the IAB associated meeting, so doesn't mean necessarily we have to spend it, but we renewed some of the old resolutions to keep them from expiring, and that was done, said about 2 hours long.
Attendance like virtually versus in person.
Well,
We had all the trustees there. We had probably, 8 or 10, all the directors. And then we probably had, I don't know, 8 or 10 people that were on the health board, somewhere in the state.
Yeah.
Got online. But honestly, most of it was trustees and directors.
Well, and I guess the reason I bring it up is so I was attempting to be at the virtual Malvo. It's very difficult. I had, of course, internet problems getting bumped on and off. I happened to be in Lewiston at the time, and it was a challenge to even stay on to go to classes or to listen to presentations. So my thought is, if we can provide some sort of class presentation, I don't know what we're talking, but some sort of, maybe even more of we seem to have all the similar questions of like, how are hospitals reporting data, and maybe to get a better breakdown of that, to fully understand it so that we can go forward, getting better numbers, or if we have some sort of material that is worth providing, I think that an in-person would be great. If we're just going to do, and it sounds, winery tours, or if it's just to show off our district, then I would much prefer to just stick with the business meeting and get out. But we do, if you were to do it here in Ada County, there is an advantage of, we've just gone through COVID. We have access to some different facilities. If you look at Department of Health and Welfare, some of the labs in the area, and to give Board of Health members a better handle on on the ground functionality of how some of these epidemiology processes work. That's where I was going in my head, is if you can provide some sort of content, then I think it's worth doing in person. If we're gonna vote on resolutions, I'll give you my proxy and you can get online and do it.
Well, I don't think there was any new resolutions.
Yeah.
They were just reaffirming by the deal. Books, and that was it. 20-minute deal.
That's my thought.
I don't know, Russ. Right now, my feeling is, looking at the numbers, that I think it's probably going to be virtual.
Well, especially we don't know what this virus is gonna do.
And I'm definitely got my share of meetings, so I would like virtual, and it helps me get other stuff done. You know, it's more too, you connect with everybody, kind of. Sure. Folks in different districts, and that's worth it.
Well, last year we had that spike after Memorial Day. So,
And I think it's a lot of work for Russ and his staff to put all this together.
Donna does an amazing job.
yes.
Never fault Donna's skill for putting stuff together.
As far as being a responsible spender of taxpayer money, and in these circumstances, I think personally, virtual makes sense.
Well, and I think this is the point where we revisit why we're paying them dues. I would much prefer to get away from paying dues to the association. And then if they want to create a, you know, an event, then we pay whatever it costs to, you know, attend said event. Because that's kind of what I've always thought that though. I don't know what.
Michelle here. Do you remember what our dues are? Association.
70,000,
Like 7,000.
It's quite a bit.
Yeah.
They said they've got about 50,000 in there.
Yeah.
Yeah, that's money that you could use for social media.
Yeah.
Well, that's the other thing. Our dynamics are changing as far as the funding, it's the counties now, it's not the state that we gotta be worried about.
Yeah.
Maybe what we need to do is do our own little thing with our own four counties.
Yes.
I think that would be much more productive.
I do too.
Bring them down and show them the facilities. I know my other two commissioners, I don't think they've ever been in here before and seen this facility.
That's actually, I think, a really good point, is if we put together a dinner for our commissioners and had like a facilities tour and introduced them to folks that actually worked, that could be far more beneficial than.
I like that.
And you also have to Elle's point, we've removed the state from the funding source. And so these are all the people that are gonna long-term fund public health, so it would behoove us all to get them invested in the programs.
Well, and then next year is an election cycle, and so the following year, you're gonna have probably some new commissioners, and I think it's something we probably ought to do, or think about doing every year, is orientation for new commissioners. And what we do. We get more bang on our buck doing that than we would be inviting everybody from all over the state to come down.
I agree, because not a lot of people understand what we do.
No, and I know right now, like over the past year, we've had some conflicts between commissioners on these appointments.
Boy,
And so it might not hurt to get everybody in the room and talk.
I like that.
Sure.
Yes, Russ.
So that's a different subject. This, the IEP agenda item, it sounds like virtual is the preference.
Yes.
Do it sometime, not the week of Memorial Day, either before or after, right? Because that's always lower
we always did it
attendance.
in June, didn't we?
Yeah.
Usually the second week in June.
Which
Did
is
we already
away
do a
from
motion?
Memorial Day, so
Okay, I'll make a motion to do it the second week in June, virtual business meeting only.
Second, okay. Any further discussion? Take a vote by county. Ada County roll.
Jane, yes.
Okay, and Elmore County, Megan.
Yes.
Boise County, Ryan, are you there? You're not. Valley County?
Aye. Yes.
Yes. Three yeses.
Okay, so Madam Chair, question is then can we put on discussion or setting, since it's not an agenda item, we don't want to act on it, something that's not on the agenda, can we put on the agenda for October Elks concept of doing a district meeting? And maybe, yeah, and so then it goes on the agenda, and I'm knowing that Donna is within the sound of my voice. And so I'm anticipating that she's gonna anticipate that we are gonna want to have some sort of plan for dates and hotels and that, so. I bet you, my experience tells me.
Well, and I think you need to talk to Boise County to Ryan and see if they can afford send somebody and pay for hotel rooms to do that, because I know they're pretty tight.
But if we put it on an agenda item for
Yeah,
October and have that discussion.
Madam Chair,
Yes.
one other point of greater clarity would be that first week of June, second week of June, not first week, that would be unclear. The Thursday morning, Thursday afternoon, that tends to work better than Fridays. People are doing other stuff. You guys have Thursday's been the tradition.
Run with it.
Thursday afternoon? Okay, that's what we'll do. Thank you.
Director's report, Russ, do you have anything else?
I do. That's pretty brief.
your commissioners, do they meet on Thursdays?
So there's the two things that I wanted to bring to your attention is related to legislation. So we have House Bill 73. House Bill 73 was a big, long bill. I don't even know what the purpose of it was, but within that bill, there was a little snippet of language that said the public health districts must use the Legislative Services Office for their audits. That was after we got approval from the Legislative Council last June to use a private auditor. And that bill, that law went into effect on July 1. And if you look at Idaho Code 413 or whatever the number is, 39413, that law went into effect the 1st of July. Now, the good thing is House Bill 316 allows us to use an independent auditor as long as you meet the general accounting principles. That goes into effect on March 1st, 2022. So I was thinking there was a possibility we had to provide some clarity language this legislative session, but after it was printed on the web, it looks like we're good to go. So we had a letter of engagement from March. Swigert, John and Associates did our audit. They'll be visiting with you in October, so you can meet them. They'll talk about the audit process. Our staff were really pleased with their efficiencies, some factors that haven't been quite the same using state services. It was $20,000 instead of $42,000. And we, in my opinion, Mike Kane's opinion, we're good to go, because we won't have another audit for at least another year. March 1st will have come and gone, and no legislative action will be necessary. House Bill 316, big deal, made the changes to the funding from the counties. State funding will go away on March 1st. We budgeted for that this year. The counties are set up to pay. The theory is you'll use medically indigent funds to cover the cost of the public health district budget for our 4 counties. All 4 counties will be well in the black in doing that. That's good. There were some other components which it clarified we're not state employees. That was already the case. It also added language to say we're not county employees. It's always been the case. And the health districts, with the director in consultation with the boards of health, will set rates of pay for our staff without interference from elected officials and state agencies and et cetera, et cetera. That's been a challenge, as you all know, including up to and including this year, working with the Division of Human Resources at the state, who reports to the governor, and all the other agencies that we typically work with. The bill allows us to do that, including the Division of Human Resources, should we choose to, under an MOU or contractual arrangement. So I have met with the State Controller's Office, Office of Group Insurance, DEQ, Department of Health and Welfare, and they're all ready to roll. There's no changes planned as far as removing us from our health insurance plan, removing us from Percy. None of that's going to happen. We're going to update some of our MOUs with DHW and DEQ because it says in there, according to Title 39, 400, whatever it is, they have the authority to delegate. The legislature said you don't have the authority to delegate anymore, but the MOUs are, for all intents and purposes, something we would want to continue to do. So we're all good except for DHR. There's still debate going on as to whether they would, as of the last meeting, it's kind of like you're in or you're out. we're sort of like, well, that doesn't make sense. You have a state classified system. Our employees are classified employees today. We use NeoGov, which is the software they use to post positions. We use the application process, the screening process to process for our employees. But they're, I call it a bit of a hard line of, look, if you don't let us manage everything you do, including your job reclassifications and employee salaries, then we don't think you can stay in the state merit system. So, attorneys are talking back and forth. We're meeting on September 2nd, trying to get more clarification on that. The good thing is state controller's office can and has done this for other agencies is when our HR manager submits a salary change, they have the ability to, they call it flipping a switch. So it doesn't go through DHR and DFM, it goes directly to them and they process it. So if they're willing to do that, I don't know how this is going to work out with DHR. So more to follow. No worries, doesn't go into effect till March 1st. And we've discussed among our leadership team, if we have to establish our own personnel merit policies, well, it'll just look like 44 counties and however many cities are in the state of Idaho. Everybody's already done it. We can adopt one, we can create our own. We can use the state system, except it won't be state, it'll be CDH's merit system. And I'm not concerned about that. I think it'll be easy to do. And we have an incredibly competent HR manager here to help us with that transition. So that's the update.
But they're still gonna write our paychecks every month, track all that, right?
That's all through the state controller's office.
Control.
Absolutely. Yeah, accounting systems, payroll systems, Brandon, he's elected himself, and that's his system, that's what he runs, and he is 100%, all health districts, you're welcome to stay on the system, which is what we prefer.
Great.
That's all I have. If you guys have any questions, I'll certainly give you an update on DHR at the October meeting, and I think we're good to go.
Motion to adjourn. So moved.
So we'll wait to hear from you on our September meeting.
Yeah.
Anyway, I'll take a roll call by county to accept a motion to adjourn. So, Ada, Jane. Jane. Elmore County.
Dave Blake's my eye.
Brett, Valley County.
Commissioner Ashburn, go ahead.
And Michael, too, so. Adjourned, and we'll see. In person, I hope. 15th of October, and virtually to be the adjournment.